discussion. We'll try and work through two cases here. One on chronic pancreatitis, one on acute pancreatitis. We'll be starting pancreatitis. I don't think we need to introduce ourselves. Malit is from Prof. Unit Alboida. Suchinta is from the Prof. Unit at Ragam, and I'm from Peradeniya. And we'll be starting with a case scenario on acute pancreatitis. Malit will be taking the lead and will be chipping in when necessary, but we expect most of the questions to come from you guys. So please do respond and do transfer the mic from person to person so that we can keep an interactive discussion going. Time format, we'll probably go from 8:30 till about 10 with acute pancreatitis, take a break, and then take the next hour and a half to do chronic pancreatitis. All right, over to you, Malik.
You can stay. Right. Even if you don't know, just say something, okay, and pass the mic. That's fine. I'm going to start with basics. Postgraduate is just a glorified version of undergraduate exam. There is no rocket science in it. So I'm going to start with very basics, and I think it will be the same. Is it observed history taking a discussion still? Okay. So simple case: a 45-year-old woman presents to a surgical casualty with sudden onset, worsening epigastric pain for 6 hours duration, associated with several episodes of vomiting of undigested food. So, what are your DDs in this case?
So acute pancreatitis
Okay.
and peptic ulcer disease.
Yeah.
And GORD, exacerbation of GORD.
Anything else?
Biliary colic.
Sorry?
Biliary colic.
Biliary colic. Okay. So those are your differentials. Anything else?
Can be AMI.
Yeah. Good. So, come on. How would you differentiate? His DD is absolutely right. How would you differentiate these things further?
So in case of acute pancreatitis, patient will have sudden onset severe epigastric pain, which usually related to back. In case of peptic ulcer disease, patient will have previous history of GORD or dyspeptic symptoms associated with meals and all. And case of biliary colic, similar.
And you can also ask about the risk factors, no, or the causative factors.
Yes.
Like what?
In case of acute pancreatitis, in being a female, evidence of biliary colics and bout of alcohol, any other toxins, trauma.
Septic ulcer disease, what can you ask?
Apart from the dyspeptic symptoms, I would ask complications, basically hematomesis, melena, and all.
Right. What about recent history of analgesics?
And NSAID.
NSAIDs, recent surgery or recent flare-up of arthritis or something like that?
Yeah.
Right? Trauma, NSAIDs, or whether the patient is on steroids. Right. Anything else you want to comment? So, at the exam setup, if someone asks how to differentiate, remember to start from history, examination, investigation. Never jump into examination investigations first. Some people for this question, the DD is absolutely right. So when I ask how to differentiate, if someone answers, I will do amylase as the first thing. That is, I think, not tactical. You have to go in that order: history, examination, investigation, in that order. Right. Okay. So, anything you all want to add for this part? Right. Okay. So next one, how do you diagnose acute pancreatitis?
There are three components of diagnosing acute pancreatitis: the clinical, biochemical, and the radiological evidence. So the clinical history suggestive of epigastric pain and maybe epigastric tenderness. And then the biochemical, we have a serum amylase or serum lipase increase of about 3 times of the upper limit. and the radiological evidence of acute pancreatitis.
What is the radiological evidence?
Ultrasound evidence or CT. Ultrasound.
Ultrasound or CT. Is that correct? Is ultrasound a good investigation for pancreatitis?
No, sir,
No, why?
because the pancreas is in the retroperitoneal organ, so it's obscured by the.
So what you mentioned was Atlanta criteria for diagnosis. In that, the imaging means it's not ultrasound. It's either CT or MRI evidence. Right. Okay. Does that mean we do MRI or CT for each and every
Also inconclusive.
in
cases of-
inconclusive cases? So it is not ultrasound scan. We have to do ultrasound scan for a different purpose. We'll come to that later.
So how do you diagnose acute coronary syndrome? Just to compare them. How do you make a diagnosis of acute coronary syndrome? You've heard about this, no? What would you do? You have clinical criteria, ECG and biochemical. And if you have 2 out of the 3, that is ACS. Acute pancreatitis is very similar. Right? Just to explain what Malik was talking about with ultrasound not being good, what's the problem? Why isn't ultrasound good? I know we say it's not sensitive and all that, but what's the problem? What happens when you have acute pancreatitis to the bowels? You get ileus and you get gaseous distension of the transverse colon and the stomach. And then you have the classic term with our radiologists give us when we do, which is obscured by bowel gas.
Yeah.
Right? So it's just behind the transverse colon and the stomach, and both those distend. So you're not going to get a clear image, right? When do you do imaging if you don't have both clinical and biochemical criteria available? And in that case, you don't want to have something just like Dr. Malik said, which is non-specific or non-sensitive. You want something as sensitive as possible. Sorry.
Right. Okay. This question I put basically to highlight, because even to date, now what is the answer for this question? No, I'm very happy to see a lot of no's in the audience, because even to date,
First of all, you can like you have the raised amylase and then the passive abdominal pain. There's no need to do the CT immediately. And yeah, because some of the changes in pancreatitis will appear later. So it's not essential to do CT in the initial phase. But we would prefer to delay the CT as much as possible also. So just because you need to diagnose, if you have the raised amylase and the abdominal pain, you don't need to do the CT immediately. It's preferred to delay it.
okay. Right. So I'm very happy to see a lot of no's in the audience, because even today, I'm seeing lots of diagnosis cards with repeated amylase by surgeons, physicians, and all the categories, right? So we do not have to repeat amylase. It is only for the diagnosis. It does not predict the severity. It does not predict the outcomes or the prognosis. We get calls by saying, we have a patient acute severe pancreatitis. Why do you say so? Because amylase is 3000, right? So it does not, the value does not predict the severity. So remember that. We do not have to repeat amylase and put arrows and document in diagnosis card the subsequent values. The trending down amylase does not mean that the patient is recovering. I am sure we have come across this scenario, most of the patients.
Yeah, usually when someone is communicating to you, it might not be a surgical doctor. We tend to get that feedback, which is patient came with an amylase of 3000, but now it's progressively dropping over the past 2 days, and so we think it's improving. So like Dr. Malik said, that's meaningless. That's just a waste of money.
Yes, okay. Okay, can someone describe the pathophysiology? It's very important to understand the pathophysiology of this disease for you to treat with a, then you know why you are treating like that.
Actually, two causes that the common causes alcohol and gallstone.
Okay.
Usually, one is direct essential injury, or it can obstruct the duct, causing release of activated pancreatic enzyme, which cause inflammation, progressive necrosis, hemorrhages, and also the widespread release of the inflammatory mediated into the systemic circulation, causing endothelial injuries and progressive multi-organ injuries.
So what is the difference between this inflammation and other inflammatory conditions like acute cholecystitis, acute appendicitis? Is there a difference? Your pathophysiology is right, but is there a difference in this inflammation? Why are we so worried about this inflammation?
Yes, this is rapidly progressive into systemic inflammation. Not-
So the cytokine release, the inflammatory mediated release is, it's out of proportionate. We call it a cytokine attack or cytokine surge. So therefore, the vascular permeability is increased and extravasation of fluid. Those things happen out of proportionate. So therefore, that is very, very important. That is the difference between in a normal other inflammatory condition and acute pancreatitis. And when do you see these things? In the first part of the illness, first week of the illness, or in the second week of the illness?
Usually first week.
First week. So the natural history is such that the first week of symptoms are mainly due to the release of inflammatory mediators and the systemic effects. By any chance, if the patient progresses to second week and does not recover within the first week, that means patient is likely to have worsening of organ failure plus or minus local complications. This is the natural history, but we have seen patients with pancreatic necrosis on the very first day as well. But generally, the natural history is such, the first week symptoms are mainly due to systemic inflammation. Second week, it is due to the worsening of the systemic inflammation plus or minus the local inflammation. So what you need to remember about the inflammation is a cytokine attack. So widespread release of cytokines, out of proportionate release of cytokines, and increased vascular permeability and vascular leak. You all want to add anything? Anything to say about this? Okay. So it's very important to know that, because then you know why we are treating like this, this condition like. Okay, so we have already discussed. Can you just summarize to say what are the indications? When would you consider CECT in patient with pancreatitis?
The indication of CECT can be divided into the phase, the early phase of CECT. Only the indication can be used as a problem solving tool. So if the patient's clinical picture is very similar to acute pancreatitis, but in the absence of elevated pancreatic enzymes, we can use this as a CECT for the problem solving. At the same time, sir, if the patients present bit late, we use this. In the late phases of complications, after 40 to 72 hours for diagnosis purposes of complications, especially if the patient, irrespective of medical resuscitations, clinical pictures get deteriorating, then placed to go for CT to identify the necrotic infective pancreatitis. And for the diagnosis purpose, obviously for that, sir.
Yes. So you have mentioned 2. Any other indication?
And if we suspect any complications, especially in elderly patients, more than 60 years patient, first episode of acute pancreatitis, most of the time some pancreatic malignancies can be present
To ascertain a cause, if there are no obvious causes, to find out a cause. In that case, when would we do it? During the illness or later?
later, sir.
Later. Why?
Because in acute states, there should be the inflammatory changes in the pancreas. So it may definitely obscure the acute etiology in the CECT. For get the picture of imaging, I would prefer to go for later part of the disease.
Very good. So because of the inflammation, the small tumors can be missed. So you have to wait at least 6 weeks for the inflammation to settle and then do a CT. If you are doing the CT to ascertain the cause. Right. So these are the causes. These are the reasons. Diagnostic doubt. When local complications are suspected, as he correctly mentioned, if the patient failed to respond to your medical management within 72 hours, or if patient is deteriorating, that means you have to suspect local complication. And then the third one is to ascertain a cause. Right. So how will you see the necrosis? Anything you want, if you want to add anything, just.
I think regarding when local complications are suspected, there are two instances where we do that. One is in the acute setting, when the patient comes in and, like Dr. Malik said, he's not improving and you want to see whether there's. Sometimes we have a diagnosis of severe pancreatitis with a large area of necrosis and the patient improves and they are ready for discharge also. But some units, I'm not sure whether it's a recommended practice, but some units have a practice of doing a contrast CT in those severe pancreatitis patients somewhere around 8 weeks post-event, because they want to look for delayed local complications, which I think will be
mainly pseudoaneurysms.
Yes.
Otherwise, you think that the patient is doing very well and discharge the patient, and then again patient comes to the casualty with circulatory collapse. So because pseudoaneurysm are the known but fatal complication, so I don't think it is there in guidelines to do a CT like that. But if the patient has severe necrosis, it's better to perform an interval CT to see whether the patient is developing a pseudoaneurysm. They can be very silent and can come with catastrophic hemorrhage. Okay, so how will you, what will you see in a, Hank, you want to answer? So what will you see in a CT scan? If you do a contrast CT scan, we are mainly looking for necrosis. How will you see that?
Depending on the stage of the extent of the damage, sir, they will usually have a hypoechoic collection within either in the peripancreatic region or intraparenchymal also we might see. If there's and also if it get infected, we might see emphysematous pancreatitis. We can see intraparenchymal gases bubbles, and if it is a hemorrhagic one, if there's active bleeding, we might see active bleeding also. But in that case, patient will be more in shock situation other than that.
Yeah. So as they correctly mentioned, you will see a non-enhancing area in the normally enhanced pancreas. So that is the necrosis. Sometimes you can see this within the parenchyma, and sometimes we call it peripancreatic necrosis. That's okay. The arrows indicate the non-enhancing area of the normal enhancing pancreas. That is the pancreatic necrosis. And this one also you can see another one, and also some peripancreatic fluid collections close to the tail. This is the other one he mentioned. This patient also has necrosis, and you can see a lot of gas. That indicates it's an infected pancreatic necrosis. In an unintervened abdomen, we have not put any needles or drains, and there's a retroperitoneal necrosis and gas in it. That means it's an infected pancreatic necrosis. You don't have to do a FNA and culture to prove that this is infected. This is the indication to start antibiotic with regards to pancreatitis. We'll come to that later also. So these are the CT findings. Okay, next one. Severity assessment. Unlike in other acute inflammatory conditions, we are mainly assessing the severity of acute pancreatitis. Why it is important to assess severity of a disease in general?
For the management purpose, we have to categorize the severity of whether it's a minor or not severe to decide on the escalating the pace of management, whether the patient needs ICU, HDU care, or any other intervention. So there are several clinical
and also between hospital, whether to keep in a base hospital or
transfer to a
specialized center. Yes. Any other?
To assess the prognosis of the
Yes, to assess the prognosis of the disease. Anything else? If you are in the periphery, if you want to call one of your bosses in the center to transfer this patient, isn't it easy to start with the severity score rather than telling I have a patient coming with epigastric pain with amylase of 1000 and having this and that. You can start your conversation by saying, I have a patient with acute severe pancreatitis. Then the receiving end person knows, okay, you're talking about a patient with this and that, right? We'll come to that later. So that is for scientific communication.
Yeah, universal.
Yeah. Anything? Any other comedy chances? Yeah, this is not regard to pancreatitis, for assessing severity of any disease for that matter. Right. For research, auditing, and all these purposes. Right. Okay.
Yeah. So in communication, one thing that we keep re-emphasizing, because this is very lacking among our community also. It's not only communicating with your seniors or communicating with the station you are transferring. It's to communicate with the patient and the relatives. Because people want to know why there are two guys with pancreatitis who came with the same pain, but one of them dies 3 days later in your ward. Right? Unless you have briefed the relatives and the patient on the prognosis of a severe pancreatitis as opposed to prognosis of mild pancreatitis, you can't circle back and talk about those things once the patient dies. Right? So, especially pancreatitis, remember, it's always better to communicate ahead. Right? Inoperable malignancies, pancreatitis, or any malignancy where you have a high mortality, morbidity associated with the cure, also communicate ahead. So hopefully use the first opportunity you have with the relatives to tell them. And this is what gives you the survival rate. So that's why that's a very important reason that you have to assess the severity.
And not for exam purposes, for day-to-day practice. When someone says, I have a patient with severe pancreatitis, ask, why do you say severe? Does he have organ failure? Otherwise, as I told you, they say it's severe just because amylase is in 3000s, right? So before you accept the patient, ask why you are saying it's severe. Otherwise, you are just accepting a normal eating and drinking patient with amylase of 3000. Now, they have repeated amylase also, it has come to 300, right? So there is no point of accepting such a patient. So what are the scoring systems? You know,
there's a later scoring system also earlier
can't hear you, Buta.
in there are scoring system for the early like for the severity assessment and for the later thing. Ransom score and
Sorry, I can't hear you. I don't know. The others can hear you.
Why do we have so many scoring systems?
no, still there's no no.
When one disease has so many scoring systems or treatment modalities, what does that imply? None of them are perfect. None of them are perfect, right? That's why we have so many systems. Right. So we have many scoring systems. There are older ones and new ones. New ones are also not that new, but compared to the older ones, they are new, right? Not ancient. So can you name few at least? Can you pass the mic?
Yeah, we can categorize this all scoring system according to the organ specific and the disease specific, as well as the systemic evaluation and single markers. There are a few scoring system with the organ specific, such as Ranson's, Glasgow, as well as those scoring system. At the same time, the severity can be assessed by the revised Atlanta criteria. At the same time, other non-organ specific scoring systems such as biceps, Apache also can be used. A single marker such as CRP, other few scoring system that you are using in current practice.
Can you tell me the difference, the advantages, disadvantage of these scoring systems?
Some of them at the beginning we can use as a initial screening tools. At the same time, a few of them are has to be used in a stage manner at the beginning as well as the has to assess at the after 48 hours.
Like Ranson's.
Ransom score. So those are the drawback of those scoring system, even though they are effective.
If you compare Ranson's with Revised Atlanta, what are the advantage of Revised Atlanta?
Revised Atlanta has a radiological imaging modalities has also included into the scoring system, which gives the anatomical evaluation of the severity by the complications that patients acquire.
So as I told you at the beginning, the natural history has two phases, the systemic inflammatory stage and the local phase. So Revised Atlanta use both, whereas if you look at Ranson's, they only assess the systemic. And the number of investigations that you do for Revised Atlanta and Ranson's?
In the Revised Atlanta, it's minimal investigations to see organ failures as well as imaging. The Ranson's, we have to use calcium, glucose, and oxygenation levels in the blood.
So many investigations.
So many investigations are associated with it.
So that's very good that you gave a nice brief account there. From a practical point of view, what issues do you see doing a ransom score as opposed to a Revised Atlanta in your ward in a surgical casualty?
Availability of the sources. At the same time, we are receiving in the ransom score, we have to have the ABG as well as the calcium levels and
LDH.
LDH and availability of the investigations practically not possible in our setting. At the same time, in the Revised Atlanta, we had early imaging has to be done to assess the local severity of the disease. So it also with one of the drawback of the Revised Atlanta to assess the severity.
We do not do CT to assess the severity. We do CT scan if you think the patient is not improving. Just for the sake of assessing severity, we don't do it. If you think it's a mild acute pancreatitis and patient is getting better day by day from first day to the third day, we don't have to do any of these things. It's a clinical decision. We don't have to do all the investigations to assess severity in each and every diagnosed patient pancreatitis. If the patient is not doing well, next day patient is abdominal pain is continuing, patient is tachycardic, tachypneic, those are the early signs. Then you think, okay, this patient is not doing well. That is the time for you to decide on one of the scores and intervene. Otherwise, we don't do CT scan just for the sake of assessment of severity. Okay.
So, are we going to be discussing each of the scoring systems separately, man?
I think you don't need to know any of these things by heart, but at least you should know the names and which ones assess the systemic complications, which one assess the local complications, and I think we need to know about in and out about Revised Atlanta. What do you think?
Yes, I agree. Most of the others are out of date. You probably need to know the reasons why some of these are not practical. For example, if you go with ransoms, the main drawbacks are you have a set that you do. We had to memorize ransoms when we were training. But I don't think it's necessary now because we have moved on to Revised Atlanta and it's much simpler, right? So ransoms, the first investigations, by cell count, AST, you can do. Age you can assess, sugar you can assess, but LDH in a night casualty, you can't get an LDH done. So you can't store the immediate ones there. And ransoms does check local complications to a certain degree in the 48-hour one because it looks for sites of extracellular fluid sequestration, right? If you have more than 6 liters of fluid sequestered extracellularly, that is a point of scoring for in the ransoms in 48 hours. It does look for that. But again, it's a laborious process and you have to repeat it. So those are the disadvantages of ransoms. Advantages are it's shown to be quite predictive for severe pancreatitis, right?
I think if the score is more than 3, it predicts
That's
3 predicts the
Same
severe.
for Glasgow. Glasgow is very similar. It uses serum albumin, which Ransom doesn't have, but they are very similar. Balthasar is really great for local.
Mainly for
It's called the CT
necrosis.
severity index of local. But you have no idea about what is happening with the systemic inflammatory response. You have no idea about what's happening due to substances released by the pancreas into the blood. Like, why do we check LDH in Ransom's? What happens? Pancreatic lipase gets released into the blood, no? And the lipid bilayer of the red cells gets destroyed. And you have hemolysis. So you can't assess those things with balance. So you'll need to be able to at least talk about a few advantages and disadvantages. Memorizing the scores, I don't think is necessary. Then if you go to CRP and bicep, they are probably the simplest and easiest to do. Bicep stands for bedside index for the severity of acute pancreatitis. It all stands for the things that you do. E for blood urea, I for impaired mental state, S for SIRS, age, pleural effusion, all those things you can do. You just need to have blood urea and a chest X-ray. Everything else is clinical letters and white cell count. But they are not very sensitive. CRP.
It's a new marker, not that new, but only thing is lot of false positives.
Right.
That is the main problem.
I mean, we commonly encounter pancreatitis with cholangitis and things like that. You are going to get a completely wrong CRP and your assessment is going to be.
What is the cutoff value in CRP? 150 at 72 hours, is it?
48 hours.
48 hours. Yeah. So
150 cutoff is there in colorectal surgery also for discharge from patients. You probably know about that. Okay. So then we come to revised Atlanta, you know about. So we'll talk about the other one, Apache. Now the main disadvantage with all the criteria we talked about earlier is that they talk about what physiological derangements are there in the patient. But they don't care whether these derangements are happening in a 70-year-old with 2 MIs and COPD, or they're happening in a fit 20-year-old. Right? The only thing they take into account is age. Ransom's and bicep take age into account. So they are checking your acute physiological derangements. But as you grow old, you end up with chronic health problems also. So Apache is an acronym. Anyone knows what it stands for? It is your acute physiology and chronic health evaluation. Right? And as you can probably understand, it's an extremely laborious thing. You have to go through the patient's comorbidities and work out how bad they are on a scale in the NYHA and things like that. Those are very difficult to do. So Apache is probably for ICU and for research purposes.
So those actually is non-specific. You can apply Apache to any patients who are in ICU HDU. It is not for pancreatitis only.
Prognosis is acute physiological changes and the chronic health determinants. Those are the two things that affect prognosis, right? So those are probably the disadvantages and advantages you need to talk about in each of them. And finally, regarding the Atlanta, you probably need to know details.
Yeah. This is Apache, bicep. Okay. So revised Atlanta. So what is the advantage of revised Atlanta over all the others? Then because it takes 2 things into consideration: systemic and local complications. So how do you assess the systemic complications? What are the commonly affected organs in pancreatitis?
The lungs leading to ARDS, kidneys, acute kidney injury, altered mental state, hematological manifestations, hemolysis, and
the cardiovascular,
DIC and cardiovascular.
Right. So how do you what is the scoring system? I've already mentioned here. we use the modified Marshall score. Remember, modified Marshall score is not a scoring system to assess the severity of pancreatitis. It is a scoring system that we use to assess the organ failure, right? So we can put all criteria. You don't have to buy out any of these things because we have tabs and smart devices. That's one of the reasons we don't expect people to buy out any of these scoring systems anymore. But you need to know what to be done for the patient to assess the scoring system. We don't encourage anyone to remember what is there in each and every category. But if you know what investigations to be done, with the use of those investigations, you can apply that to Metcalc or something like that and calculate the severity. So this scoring system, we are mainly assessing 3 organs. That is CVS, respiratory and kidney. CVS we check systolic blood pressure, very simple. And kidney, serum creatinine. And then respiratory. Anyone?
PF ratio.
PF ratio. PF ratio. So you need only a ABG and a creatinine and a systolic blood pressure measurement. Compared to Ranson's, it's very, very less labor intensive. So that is one of the main advantage. And the second main advantage of this is we take both systemic and local into consideration to make assess the severity. Do you want to add anything? You want to add anything?
Yeah.
Because
Sorry.
some people have heard saying the modified Marshall score as a severity assessment score. It is not.
So now I think we come to the end of diagnosis, isn't it?
Yeah.
So the important point for you now is when you are faced with a patient, right? Your patient doesn't come with a board-sake pancreatitis on the forehead. So on one hand, you're going to be doing this, and on the other hand, you're going to be doing investigations for the other differences that you talked about. And you must be able to, if you're given a case scenario, right, present this in a smooth way. You will have your resuscitation going on, you will have your investigations going on, and when the cannula is going in, you will have to list the investigations you need for the Atlanta, along with your troponin and the other tests that you need to exclude hepatitis or whatever, all those factors for the differential, you need to rule out that you're going to take in the blood sample, right? And in addition to that, that you want to do a AB.
That should be the thinking pattern for any disease. If the patient comes with loin to groin pain, we know that it is ureteric colic. But you have to think, is it ureteric colic or is it not? Otherwise, you are going to miss other differentials. You don't have to entertain all the possibilities and rare diseases. But you have to think, okay, this looks like obvious ureteric colic, but it could be something else also. If you don't think like that, you will treat every loin to groin pain as ureteric colic, and you will even miss a ruptured AAA.
Yeah, exactly. So that part is where I think at the essays as well as at your vivas, they will find who is reading from a book and who has done this 10 or 15 times as a registration. Okay. So you face a patient with acute upper abdominal pain, you have to have some kind of frame in your mind that you are going to be using on the patient over and over and over again. Right? You're going to do these things while the omeprazole is going in through the cannula. Before that, you have to check whether these investigations are like that. You have to have some kind of form. And all of you have HOs, right? Drilling this over and over again into the HO and giving them that stage of, that is how you are going to work that pattern. And that is what is going to set you apart from someone who has read this in the book, has read basic resuscitation in a book, and is trying to put the two together in front of the exam. Okay. So
the scoring systems best way is to apply it in a patient and see. Then you will know what is difficult to do in a practical setting, what is practical and what is helpful. So rather than, I can't remember any of these scoring systems properly. Is to apply to a patient that you will at least remember what is useful and what is not useful and what is practical.
And the other thing is observe history taking. It has to be methodical. Your history taking has to be methodical. You can't ask bowel habits and then ask social history and ask about urinary symptoms likewise. just because you ask all the question, you don't get marks. You have to ask in a somewhat methodical manner. So if a patient comes with, as he said, the patient doesn't come with a diagnosis in the forehead saying acute pancreatitis. Patient comes with upper abdominal pain. Entertain all the differentials one by one. If you're thinking of peptic ulcer disease, ask about past episode and ask about whether the patient has taken any analgesics recently, and a patient has been on any like prednisolone recently. So that is with regards to peptic ulcer, and leave that, and then move on to pancreatitis and ask about similar episodes in the past. Right? And if there are similar episodes in the past, how many? And how many of them were admitted to the hospital? If it admitted to hospital, how many of them were managed in the ICU? So you can ask like that. So then you can say this patient has recurrent acute pancreatitis with 10 hospital admissions. One of them were managed in the ICU. So otherwise you're going to miss the bus. It's a patient with acute on chronic pancreatitis or recurrent acute pancreatitis. If you think it's acute on chronic, you can ask more about the chronic complications, which we'll discuss in the other case, like endocrine and exocrine failure. So likewise, it has to be methodical. Then you can move to symptomatic gallstone disease. So otherwise, your history is everywhere. It's not a nice history to listen to. Okay. Okay. So I know everyone knows about this mnemonic, the etiology. So apart from managing the patient, symptomatic management of the patient and doing investigations to assess the severity, parallelly, we need to do some investigations to find out the etiology, because some of the etiologies are treatable, some are not. So how do you evaluate for etiology? Who has the mic? How do you evaluate for the etiology?
In the acute stage, so in your clinical history, you will be asking about certain risk factors. And for example, if there's a recent history of alcohol ingestion, past history of biliary calculi, or etc., and his recent history of trauma, medication that he's on, etc., and so that component will be covered in the history. And investigation-wise, the main thing is to do, at least we spoke about ultrasound scan, which should be done within the first 24 hours to exclude or to look for gallstones.
So if the patient has taken alcohol on the day before, will you do the ultrasound scan or not?
Yes.
You still do the ultrasound scan?
Yes.
You're not going to just label the patient as having acute alcoholic pancreatitis?
No.
Good. Yeah. So irrespective of whether the patient has taken alcohol or bitten by a scorpion, you still have to do a ultrasound scan, right? You can't be judgmental and say that is alcoholic pancreatitis, because if the patient has gallstone, you have to give the benefit of the doubt to the patient and treat gallstone pancreatitis. But let's say patient has gallstones in the scan and patient has also taken alcohol. What other investigations that you have already done will suggest that this could be due to gallstone pancreatitis? You get my question? You have the mic. A patient has taken alcohol, right? An ultrasound scan that you have done within 24 hours shows gallstones. What investigations that you have already done will suggest that this could be alcoholic, gallstone pancreatitis rather than alcoholic? Get some idea.
Even with the ultrasound scan, if the external biliary system is dilated with the distal gallstone, that means suggest a gallstone.
Fair enough, right? Any hematological investigations will be that will be helpful?
AST, ALT will be elevated. With the ALP is more specifically ALP is elevated.
Yeah. So it is the AST and especially ALT. If it is more than 150 on admission, it has a very high predictive value. Sensitivity is more than 98% or something. Huh?
More than 8% idiopathic pancreatitis.
Yeah.
They have found out ultimately they end up having a sludge. Not seeing the ultrasound or the mass.
So it's a very good indicator. More than 90% sensitivity. If the ALT on admission is more than 100, sometimes AST and ALT both, more than the ALP and the gamma GT. So if patient has taken alcohol and if the ultrasound scan shows gallstone with a ALT of more than 150, you can actually treat that as a gallstone pancreatitis. But if the patient is a chronic alcoholic patient with damaged liver, ALT and AST will be high. So it's always benefit of the doubt, because alcoholic pancreatitis, the only treatment is you have to ask the patient not to take alcohol. to prevent it. Gallstone pancreatitis, you can get rid of the gallbladder. It's curable. Right. So you need to make a clinical decision in that case. Okay. What are the other, let's say a patient has not taken alcohol, no ultrasound scan does not show any gallstones. How do you proceed with regards to the evaluation for the etiology?
So other etiological factors, we have to see the investigation triglycerides and calcium level because to exclude hypercalcemia.
When would you do calcium levels? If you want to evaluate as a etiology, when would you do it?
After the acute episode, because in the acute episode, the calcium level might be low because of the disease pathology.
Yeah. If you want to take that as a course, then you have to do at least 2 to 3 weeks later. Otherwise, you will miss the hypercalcemia. But if the course is hypercalcemia, it will not be so low. But still, we don't do it at the initial setup. Whereas triglycerides can be done. When would you attribute that this could be hypertriglyceridemia induced pancreatitis? Now, upper limit is 150 milligram per deciliter.
More than 1,000?
Yes. That is a very arbitrary cutoff. If it's 900, till you can say it. Right? So it's hypertriglyceridemia induced pancreatitis. Next one.
Does the serum amylase level tell you whether it's gallstone pancreatitis?
Serum amylase is only for diagnostic purposes. It doesn't say about the etiologies.
Yeah, that's the blanket statement that we should say. Very high amylase levels are associated with gallstone pancreatitis. Okay, that doesn't mean that you're going to say it's gallstone pancreatitis because the amylase is high, but that sometimes gives you a clue. Gallstone pancreatitis is known to cause extremely high serum amylase levels on the first day compared to other causes.
Right. So how do you, let's say calcium normal, triglycerides normal. How do you proceed now?
We have to further ask about the drugs like acetioprine, recent steroid injection.
Okay, you have taken that in the history. His patient is not on any medications, not on steroids, not on acetioprine, not on valproate.
Any examination findings suggestive of autoimmune diseases? Like
You can ask for other autoimmune diseases. If you want to exclude autoimmune pancreatitis, what is the investigation of choice?
not sure.
Next.
I can suggest the ANA.
ANA is very non-specific, but it will be high. Specific ones?
AN ka PN ka. Sorry. AN ka PN ka also.
No.
There is pancreatitis that occurs due to autoimmune reasons.
Yeah.
Like in polyarthritis nodosa, SLE, things like that. Autoimmune pancreatitis is a separate
entity.
Right? So what Dr. Malik is asking is about autoimmune pancreatitis.
Sure. IgG4. Having said that, we don't do it in the first episode because it's very expensive, not available in the government sector. It's in more than 40,000 rupees. You have to send the sample to India and get it done. Not available in the private sector either. So most of the time it becomes negative. Even in the presence of autoimmune pancreatitis, it can become negative. There are a category of autoimmune pancreatitis with normal IgG4. There are with high IgG4. The steroid response depends on whether it's positive. I think the IgG4 positive ones are more steroid responsive and the chance of relapse is less. Whereas IgG4 negative ones, they don't respond well to steroid and the relapsing chances are high. Right. And there are other things you can take from the imaging, which would suggest autoimmune pancreatitis, like a sausage-shaped pancreas. Right. Okay. Any other investigations? Next person. To find out the etiology. Let's say all these are negative and patient has no, now in other countries, they do IgM for Epstein-Barr virus, cytomegalovirus. In the unit that I was in, they do everything. Cytomegalovirus, Epstein-Barr virus, mumps, right? So, I mean, we don't do any of those things. But in our setting, let's say all the common etiologies you have excluded. Now, where are you now? What are you going to do?
So it could be a idiopathic pancreatitis.
you have to do more investigations before you label the patient as idiopathic pancreatitis. Idiopathic pancreatitis is the last label. Any imaging that would be helpful at this stage?
For the small stones and all, we can diagnose by doing the MRCP.
Okay, so stones that are missed in CT, ultrasound scan, actually you can go for MRCP. MRCP is good to detect microlithiasis, but still you can still miss biliary sand, small sludge. The investigation of choice would be endoscopic ultrasound scan, but it is not there in the protocol. Right. So first investigation is for gallstone disease, ultrasound scan, then MRCP. If you still think, let's say ALT is high, bilirubin high, ALP high, but ultrasound does not show gallstones, then you can go for MRCP to see whether the patient has microlithiasis or biliary sand. Still, it can be negative. So sometimes, as Suchinta correctly mentioned, we come across patients with recurrent acute pancreatitis, and we still think it is gallstone, but all the investigations are negative. Sometimes we do a trial of cholecystectomy and some of them get better and some don't. And those people fall into the idiopathic category. Right.
What else do you look in the MRCP other than the stones?
Yes. So let's say patient is 20-year-old.
So some anatomical abnormality like the pancreatic diversum, it can cause a recurrent bouts of acute pancreatitis.
Yeah.
Yes.
Yeah, it's a treatable thing. You can look for any anatomical anomalies. So when would you do, if you are suspecting anatomical anomalies as a cause, when would you do the MRCP? Following the acute episode? Immediately or later? Anyone? It should be done later because of the inflammation. As small tumors can be missed, even the ductal anomalies can be missed because we come across patients, recurrent acute pancreatitis, MRCP normal, and when it was done during the acute phase. And if you repeat the MRCP once the acute episode settles, sometimes we pick up small anatomical anomalies, then we can treat. Right. So if you are looking for a cause, the CT or MRCP should be done once the acute inflammation settles, not during that. So these things are very important because when you get a patient, you can ask, make a koi kaala kare. Admit la inna kaala kare, atham passe kare. Right. So it's very important to time this imaging. Right. Anything else? Let's say patient is elderly. I think we have already discussed that is the third indication that we discussed for CT. If the patient is elderly, if there is no obvious cause, once the acute inflammation settles, it's better to do a CECT pancreatic protocol to identify small tumors, sometimes even IPMNs. So because they can block the duct, right? So this is how you basically investigate for a cause. If there are no causes still, and patient has past history of gastritis treated by the GP, it's likely it is a patient coming with recurrent acute pancreatitis. Let's say a young patient comes to you with first episode of acute pancreatitis, and you have not found a cause. And when you dig into the history, patient gives you a history of gastritis and treated as upper abdominal pain, treated as having gastritis by the GP. This is a very common scenario of acute and chronic pancreatitis patients. So then there you can actually do a genetic studies, especially in young patients. Again, we don't do it. Sri Lanka.
Yeah. So this I at the top, it might be easy if you think about that I has actually three separate eyes. There is idiopathic, the true idiopathic, but inside that you have two other eyes, which is what we call inborn, right? Those are the anatomical abnormalities that you get from birth, like the divisome, the annular pancreas, things like that, and inherited, which is the hereditary causes, right? Can someone name some common hereditary causes of recurrent acute pancreatitis?
The genes.
Any diseases you know of that are associated with pancreatitis? We don't check for this. Cystic fibrosis, yes. So PFC gene sometimes needs to be checked for. What else? You learn about this in biochemistry in your second year in medical faculty. Alpha-1 antitrypsin deficiency, right? Those are things that you can, those are things that cause pancreatitis, but we tend to miss them because we never knew, right? And in fact, some of the other genes that are associated, like the SPINK gene, have you heard of that?
Yeah.
Those are also things that cause antitrypsin, antiprotease deficiencies, right? So they cause automatic activation of the pre-pro enzymes inside the pancreas. If you check for them, your idiopathic percentage becomes less. But none of those are currently available in the government sector. Sometimes private sector genetic studies are available. You have to send to India sometimes. They cost around 100,000, I think, to do. Right?
Having said all these things are done in a patient with recurrent acute pancreatitis, where the obvious causes are excluded, right? We don't do all this investigation in the very first episode. We come across a lot of patients with recurrent acute pancreatitis with no obvious cause. Either they are recurrent acute pancreatitis or they are acute on chronic pancreatitis, where the chronic features have not yet developed. Because we will discuss about chronic pancreatitis later. So this is a problem. Any recurrent acute pancreatitis can cause chronic pancreatitis. We know acute inflammation can cause chronic inflammation. So similarly, recurrent acute pancreatitis can lead to chronic pancreatitis. And there's an entity, acute and chronic pancreatitis, where the chronic features have not yet developed. So when the patient develops chronic pancreatitis, we don't know whether the patient actually developed chronic pancreatitis due to recurrent acute attacks or whether the patient had acute and chronic from the beginning. We still don't know. There is no answer for this question.
So again, to demonstrate how theoretical this is and how little of this you're going to practically use, hands up the number of you who have had a patient with recurrent acute pancreatitis. Hands well up.
Almost all.
How many of you went through the BNF and look for pancreatitis as an adverse effect of any of their drugs?
Because we always think about valproate, azathioprine, and what is the other one you think? Steroids.
Okay, so that's the gap between what you memorize and what you actually put into practice. Right? So that's something that you should be doing routinely. Just because they are not on steroids, just because they are not on any azathioprine or whatever, you don't say that. You have to go through many drugs cause pancreatitis as a sign.
In general, drug-induced pancreatitis and viral pancreatitis don't give us severe acute pancreatitis. Most of them are mild.
Yeah.
That I have seen. I don't know whether you have seen severe acute ones.
It's not severe, but it can come. I mean, it's a recurrent cause. Sometimes.
Yeah, it's a recurrent cause.
You have to go through at least go through some kind of medical formulary and see. Right? So we are at that level. You don't. So obviously, genetic studies and IgG4, those are way beyond that. You have to exclude all those things before you go on to the expensive steps, right? So again, the stress from my end is keep doing this with patients. The more you do this with patients, the better you will be at working out what to do.
This is a slide. I think there's a very good article in American College of Gastroenterology, acute pancreatitis, free download article. It's not updated, but I think the facts are still valid. This was taken from that. ACG guideline, acute pancreatitis. You can free download that article. So this is what we discussed. To ascertain the etiology, we start like this. All patients need ultrasound scan abdomen, irrespective whether the patient has taken alcohol or not during the first episode. But if the patient comes with second episode also, you can do it if it is not done in the first episode. And you have to make sure the ultrasound scan is done with at least 6 hours of fasting. Otherwise, you're going to miss gallstones. Sometimes we do ultrasound scan immediately. House officers send the patient for ultrasound scan immediately because patients come with acute abdominal pain and it is negative. So ultrasound scan has to be done fasting to detect gallstones. So those things you need to ask retrospectively whether the scan was done with fasting or without fasting. So these things we have discussed already. Okay, so we have moved on to the management. Any questions you all want to ask? From the things that we have discussed?
Yeah. So yeah, before we come to management, we'll try and clarify any doubts that you guys have. Is there any questions?
Yeah, I mean,
Yeah.
Triglyceride levels at what stage would we do it? Would we check for, like, if we are checking for triglyceride levels, like to determine the etiology, at what stage would we do it?
if ultrasound is negative, and if you don't think it's an alcohol as a cause, I would do it in the acute setting. But having said that, when you take blood in the initial investigations, you know that it is a patient with hypertriglyceridemia. Blood will be yellow, trust me. We have a patient currently in our ICU. Blood has a yellow sediment, not the serum and the clot. It has a thick yellow sediment. You know it's a patient with hypertriglyceridemia. It is not red.
Lipase levels in the diagnostic purpose, because both the amylase and lipase levels can be both done for the diagnostic with biochemical.
What is available in the state sector?
The amylase.
Amylase. So we do amylase. If amylase is negative, if it's late presentation, you can go for lipase. If amylase is high, you don't have to do lipase, because even lipase, they don't give any idea about the severity or anything, just for the diagnosis. If amylase is negative, if it's a late presentation, if you still think it's pancreatitis, you can do lipase.
So the typical patient is a transfer, usually, isn't it? The typical patient is a
Transfer.
transfer. Someone has been in a local hospital for 2 or 3 days and comes to us with the typical abdominal pain, it's not settling, then you might consider. Even in the private sector, I don't know about Colombo, how long does it take for a serum lipase to come around in the private sector? In Kandy, it's 24 hours.
Yeah, some hospital they don't have lipase.
So, because available in the government. So it's not something you can make an urgent judgment on, right? Let's say you have a patient who had an acute abdominal pain and has collapsed and intubated, ventilated. Now there's no way of assessing the history. And you're worried, is this a perforation? Is this bowel necrosis? Is this acute pancreatitis? You don't want to go in if it's acute pancreatitis, no? Right? And in that kind of situation, if it's a transfer from somewhere 2-3 days later, lipase might be your savior if you can get it done quickly. But practically, in our setting, the turnaround time for a lipase is also 24 hours. So you'd probably have to go with something else. I think the other instance where lipase is useful is when we get patients with renal impairment. All the time, if you are working in a unit that has a nephrology ward, there will be people with hypercalcemia. The moment they get any kind of abdominal pain, someone does an amylase and says amylase is 600, can you exclude pancreatitis? So,
and patient has no abdominal pain.
Yeah.
That's why Atlanta criteria says 2 out of 3, right? So just because patients have high amylase, that doesn't mean patient has pancreatitis. Amylase is highly non-specific. It can go up in any intra-abdominal inflammation, cholecystitis, salpingitis, bowel ischemia, PID, anything, it can go up.
Even
it may
bad H. pylori gastritis,
yes.
amylase is 200. Any other questions before we go on? Yeah.
The base for amylase level in the settings of a patient who has had a chronic pancreatitis as well as who has a previous pancreatic resection.
Can you ask? Sorry, I missed
the place for amylase level when the diagnosis of acute pancreatitis in the setting of patients who already has had a chronic pancreatitis with endocrine and exocrine failure, and also who has had previous.
So good question. Now we come across patients with acute and chronic pancreatitis in end stage chronic pancreatitis with exocrine and endocrine failure. when they come with epigastric pain, typical epigastric pain, we tend to treat them as acute and chronic pancreatitis, even though patient does not have biochemical marker, because they will not have high serum amylase level because the gland is gone. So you can still treat as acute and chronic pancreatitis. That is the situation where we treat them as acute and chronic pancreatitis, acute as with only single criteria. But you have to get the history properly, and whether it's a typical epigastric pain radiated back really well. So you can ask from the patient, is it the same pain like before? If it's different, then you have to think, because patient has intact stomach, patient has gallbladder, patient can get biliary colic, patient can come with peptic ulcer perforation. So that history, examination, investigations are very important. You can't bypass history and examination and jump into investigations. Right. So that order is very, very important. In end stage chronic pancreatitis, even during acute episode, amylase can be normal.
Anything else?
I can't hear you. Sorry.
An initial attack of acute pancreatitis, how long should we wait for the imaging, for example, for CT or MRI?
To find out the
if you want to, if you want to do a CT or MRI, how long should we wait for the edema to subside in the pancreas?
To find out the cause, right?
Yes.
Right. So at least 6 weeks. At least 6 weeks. But if patient had a necrotizing pancreatitis, I would wait for long because gland is damaged. Sometimes you can't identify ductal anomalies if the patient has necrotizing pancreatitis. Later the better.
Anyone else? Yeah.
So what's the significance of greaterness and colon signs in of a patient with pancreatitis? Is it if we see that signs in a patient, do we need to immediately act, or
that those are signs of acute hemorrhagic pancreatitis? That patient is extremely in a bad condition. That patient should definitely be managed in HDU ICU, has a very high risk of mortality.
These signs are not present in the acute setting also, because it is
no.
And none of these, as you probably know, are specific for pancreatitis. They are features of retroperitoneal
hemorrhage.
Right? There's another one called Fox's sign, where the scrotum, the blood stretches down towards the perineum. But yeah, I think what Malik said is the most important thing. They are just signs of severe pancreatitis. That's all. Yes, it's really good that you're asking questions. That's the whole point of this discussion. Anything else? Yeah.
how we exactly differentiating necrotizing pancreatitis and the infected pancreatic necrosis?
Yeah. So we'll come to that with the management, right? Good question, but we'll come to that with the management. So shall we move on to the management?
Anything else?
Any questions?
About it? Yeah.
Scan says it's focal pancreatitis. If they
Sorry?
Focal pancreatitis, if the imaging shows ultrasound scan.
Ultrasound scan. So you have a patient diagnosed pancreatitis, ultrasound scan shows focal pancreatitis.
The ultrasound scan.
And amylase is high.
Yes.
Right. Epigastric pain. So we have diagnosed patient acute pancreatitis, ultrasound scan done to detect gallstone shows focal pancreatitis. Tail region. So I would definitely do a CT in this instance, right? Now, if the patient is getting better, I don't have to do a CT scan, but later I will do a CT scan. Besides, this ultrasound scan is not we did not do the ultrasound scan to identify the pancreatitis. Good ultrasonographer will say interstitial edematous pancreatitis, IEP. That's what they mention, interstitial edematous. But if they say focal pancreatitis, they may not have seen the body and the tail. So it does not have any clinical relevance. But if the CT has focal pancreatitis, Does it have any clinical significance? Maybe a small tumor in the tail, those things can be the reason. I have seen this word in ultrasound scan, focal pancreatitis.
So is there an entity called focal pancreatitis?
Focal pancreatitis. That means sometimes the tail is only involved. And there's another one called groove pancreatitis. That is between the duodenum and the pancreatic head. The inflammation is in the duodenum and the pancreatic head, groove pancreatitis. All these, they don't have any clinical significance for the management. And also, you have heard about groove pancreatitis, right? So these are just names.
There is no rule anywhere saying the entire pancreas needs to be inflamed in acute pancreatitis. Right? That's why we say, depending on the area that the inflammation is most at, since it's an organ that crosses the midline, you can get right hypochondrial pain, epigastric pain, or left hypochondrial, or you can get all three, right? So I don't think, like Malik says, that we need to differentiate the location. What do you think, Sachin? Yeah. And especially, like you said, it's with the ultrasound scan. They are probably seeing the tail, but they are maybe not visualizing the rest of the body because of the stomach in it, right? So probably
very, very rarely it can be due to the IPMN in the distal part and then causing focal pancreas in the tail. Those are rare things. Rare things.
But pancreatitis is pancreatitis.
Yes.
Right. Anything else? We'll move on to
yes. So management. Is there a specific treatment? Is there anti-pancreatitis tablet? Unfortunately, no. So it's like dengue. So it is the supportive care, right? Non-specific. No, it's only supportive care. Okay. So we all know that hydration is the key. Earlier days we used the word aggressive hydration, but now the guideline says it has to be goal-directed therapy. So why are we talking about the hydration so much? Who has the mic now? Yes. What is the importance of hydrate in this patient?
Because on admission, patient may be having dehydration due to excessive vomiting and third space loss due to systemic inflammation and not taking oral intake. So we need to assess this and hydrate to keep the renal function going and it should be goal directed to prevent the further pulmonary edema and third space loss.
So you're right. Now in patient acute cholecystitis or in acute appendicitis also come with vomiting. And then you need to hydrate to avoid the dehydration. But here, what is if you go back to the pathophysiology, you actually mentioned there's a third space loss. This third space loss is more than in other inflammatory condition. So if you give fluid, good amount of fluid within the first few hours of the illness, if it's early presentation, these are not for late presentation, you can actually dilute the cytokine load that was secreted. So the effect of cytokine load or the cytokine attack is minimized. And also we need to keep the vascular volume intact because there's a leaking. You can't prevent leaking completely. So that is the advantage of early hydration, just to dilute. Otherwise, the dehydration prevention is there in other inflammatory condition also, because patient can't eat and drink and vomit. But here, hydration is very important because to dilute the cytokine load initially and also to keep the vascular volume intact. And the vascular leaking is less because when you dilute the cytokine load, the effect is less. That is the main advantage of early hydration. But if the patient presents after 48 hours, I don't think you can just give the maintenance dose only.
Again, I think in burns, we talk about the threshold for intravenous fluid replacement, isn't it? What's the usual threshold in an adult? 15% in a child. Why do we have those cutoffs? Why can't they drink beyond 15% burn? You need to give them fluid, yes, but why do we have that percentage cutoff for IV fluid replacement. Now, the burn also, you are losing fluid from the burn surface area, right? And there's an inflammatory response, there's an exudate, all those things are there. Skin barrier is lost. But the point they are trying to make is when you have more than 15% surface area burned in an adult or 10% burned in a child, there is so much tissue trauma that is proportional to the amount of cytokines that is released. Beyond that amount, so much cytokines are released that you have generalized vasodilatation, generalized tissue leaking everywhere. And you can't compensate with oral fluid for that. And it's the same principle that you will have here. And if you can put those two together, you will realize that that same principle is there in any bad systemic inflammatory response. Okay? So that's the issue here. There is so much tissue trauma that it's not just fluid leaking from there. And if you don't dilute out the cytokines, you will have high enough cytokine concentrations everywhere in the body to cause vasodilatation, leukocyte activation in other places also. Right? The same principle that circulates everywhere.
Right. So that's about hydration, but keep in mind about the organ failures. If the patient has heart failure or renal failure, you can't overload the patient also. So it's very important to think about those aspects. But early hydration is the key to overcome the cytokine attack. Okay, so then the other things are we are not going to discuss because patient is in pain. Of course, you need to relieve pain, and there's a theoretical risk of giving morphine because it can cause intravenous spasm. People ask most of the time whether we can give morphine. Yes, we can give morphine. That is only a theoretical risk of worsening pancreatitis with morphine. So pain relief is very important. And the other one. Now, when we were students, when we were not registered, when we were students, there was a phenomenon called pancreatic rest. Because if you eat, pancreas gets stimulated and then it can get worse. That was the understanding. But that phenomenon is not used anymore. So we can feed patients. In fact, early enteral feeding is better. Why?
So we recommend now a high calorie, low fat diet for pancreatic patients because these people, if the etiologist is alcoholic, they usually have a low amount of nutrition in themselves. So the enteral feeding can be supportive for that kind of patient as well. And keeping them fasting for a prolonged period will not help to optimize their more morbid conditions in certain cases.
So anyway, early feeding is better to maintain the nutrition. Now, with regards to the fluid leaking, if you don't hydrate the patient well, it can cause organ failure because the inflow to the organs is less. So there is a relative ischemia of organ and then organ can fail. Similarly, if you don't hydrate the patient well, it increases the risk of necrotizing pancreatitis. So in a patient with necrotizing pancreatitis, and if you keep the patient fasting for a longer duration, it increases the risk of infective necrotizing pancreatitis. Why? Due to translocation, because now you don't feed the gut is starving, the normal common cell bacteria, they translocate and then infect the pancreatic necrosis. So early enteral feeding reduces the risk of infected pancreatic necrosis. Early well hydration reduces the risk of pancreatic necrosis. Early enteral feeding reduces the risk of infected pancreatic necrosis. So
again, I think this is a general principle you need to know because we're dealing with the intestine all the time, right? So the intestine has a fatal design flaw, right? That design flaw is, now imagine your skin got a nice keratinized layer, several layers thick, right? And that's enough to protect against bacteria, no? But your gut mucosa is one cell thick. You have 23 feet of one cell thick, and on one side you have E. coli, salmonella, everything, and on the other side your bloodstream. 23 feet
just one cell thick, is all that is preventing those gram negatives from going into your bloodstream. It's not stratified, it's not keratinized, nothing. Right? So you need to have a super blood supply to keep restitution of cells when one cell dies for two cells to move together, for the lymphocytes, the mucosa associated lymphatic tissue to be there. All these things, it's a really good blood supply. And the fatal design flaw with the intestine is blood supply comes from outside to inside, which means the thing that needs the most blood, the mucosa, gets its blood supply the last. Right? And that's why the moment blood supply gets cut off, the mucosa gets the least supply. Right? And this can be in conditions like this, but it can also be conditions like obstructive appendicitis, cholecystitis. That's why the transmigration starts. Right? And intestine is not like, intestine is like a private sector employee, not like us. Right? Government sector employees are brain, heart, kidneys, regardless of whether they work or not. Right? They are going to get the same salary, same cardiac output, same blood supply. Intestine, the blood supply is completely dependent on it working. So unless you give enteral feeding to someone who is at risk of hypotension, right? The moment they become hypotensive, the blood shunts to the government sector employees and this guy fails. And then mucosa gets ischemia and you get the translocation. So that's not only for pancreatitis. In pancreatitis, there is clear evidence for what Dr. Malik is saying, and enteral nutrition reduces the septic events. But you have to know the general perspective of that organ.
Right. So early enteral feeding is recommended, provided the patient does not have ongoing ileus or feeding intolerance, so vomiting. If the patient has ileus, you can't, of course, feed the patient, then you have to go for parenteral. But otherwise, as soon as the patient start tolerating, start enteral feeding. If the patient has poor appetite, you can start tube feeding. However, you have to feed the gut, otherwise it increases the risk of infected pancreatic necrosis. So you can also give ulcer prophylaxis because it's a stressful condition, and antiemetics if the patient is vomiting, and DVT prophylaxis, which we don't use much in our country, but in other countries in the West, of course, we use the DVT prophylaxis also. Right. Antibiotic. Who has the mic? Antibiotics. What is the place for antibiotic? When to start and what to start?
In just acute pancreatitis, we don't need to start antibiotics. So
But if the patient, let's say patient presenting with abdominal pain, fever, 100 Fahrenheit, and we have diagnosed acute pancreatitis, amylase is high, and white cell count is 18,000, CRP is 80. Will you start antibiotic or not?
No, in just pure acute pancreatitis, you can have fever and raised inflammatory markers. So just having pure acute pancreatitis, you don't have to start antibiotics.
Very
Unless
good.
you
So
suspect.
this is other mistake that we do in most of the settings by surgeons and physicians island-wide. One is repeating amylase. Second thing is starting antibiotic at the outset, just because patient has fever, just because patient has high white cell count, and just because patient has high CRP. All these are inflammatory markers. If you remove your SIRS, fever, white cell count are in SIRS when you calculate the SIRS. So those are inflammatory markers. Just because they are high, do not panic and start antibiotic. As he correctly mentioned, there is no place for antibiotic at the outset. Okay. So when do we start then?
So when we are suspecting any coexisting infection, start. So like when we are suspecting the patient is having ongoing cholangitis with pancreatitis, or the late, like in the second week of the disease, when we're suspecting any infected necrosis or infected collection.
So how do you suspect infected necrosis?
So in the like imaging, as we said earlier, like in the CT, if you have like pockets, and or else we can do markers like procalcitonin, which is more specific of sepsis.
Yeah.
And the patient deteriorating despite our like resuscitation and management, can suspect infection, and then do further investigation.
Okay, so to recap what he said, no place for antibiotic at the outset. We need to start antibiotic if the patient has concomitant other infections like cholangitis, pneumonia, UTI. If the patient has the other thing for pancreatitis per se, we start antibiotic if the patient has infected pancreatic necrosis, which is clinically patient is deteriorating, high spiking temperature. We do a CT scan, there's a necrosis. If it has retroperitoneal gas, that's a clear-cut indication. But if it does not have retroperitoneal gas, then again we don't know whether it's infected or not. So that's a clinical addition. Guideline says to do a FNA and culture, but I have not seen that even in UK, right? Because it's unnecessary intervention. In that case, you can empirically start because patient is not doing well, spiking temperature, CT shows necrosis. But guideline says it is indicated only for infected necrosis. CT has retroperitoneal gas, clear cut. So otherwise, you can empirically start. What antibiotic will you start in that case with regards to pancreatitis per se?
Like carbapenems and quinolones, so they are more penetrative to pancreatic.
Carbapenems, quinolones, and metronidazole, they have a good pancreatic penetration. So those are drug of choice. If you start one of these medication at the outset, then it only increases the resistance. So therefore, no place for antibiotic in the initial stage. Right. So what is the place for ERCP in pancreatitis?
So if there's evidence of obstruction causing cholangitis, then there is a place in the acute stage.
Breast. Okay. Any other indication? What is the problem of doing ERCP in pancreatitis?
There is a risk of it inducing pancreatitis.
Yes, it can get worse. So we have to be very judicious to decide on this. In gallstone pancreatitis, in gallstone pancreatitis, it is due to gallstone at the common channel. So do we need to do ERCP for all gallstone pancreatitis?
No, usually because it's transient impaction and then migration.
Yes. So most of the time it migrates. But if the patient has acute pancreatitis and cholangitis, then that is the only indication to go for an emergency ERCP. Otherwise, we don't have to. But in subsequent imaging and blood test, it shows persistent biliary obstruction without cholangitis. Then you can again do a ERCP once the pancreatitis settles. But if the patient has cholangitis, you don't have to wait until pancreatitis settles. You have to do it. You have to get rid of at least one killer. Patient is attacked by both two killers, pancreatitis and cholangitis. Then you do emergency ERCP. Evidence of persistent biliary obstruction without cholangitis, do the ERCP once pancreatitis settles. If you are in doubt whether the stone has passed or not, what is the investigation?
MRC.
You have to do MRCP before ERCP, right? Minidu. Timing of cholecystectomy with gallstone pancreatitis.
In the setting of let's say pancreatitis with the gallstones, cystectomy takes admission. But in the case of severe acute pancreatitis, the stage supposed to be acute. So this reach out 6 to 8 weeks. Current pancreatitis during the operating time also.
What is the risk of recurrence roughly?
I think it's around 10.
More than that, it's 30 to 50%. 30 to 50. It's very high risk of recurrence. So that's why in mild acute pancreatitis, it is recommended to do in the index admission or within 2 weeks. In the moderate or severe, once the organ failures are settled, where the patient has to be fit for general anesthesia. Moderate or severe means, moderate means transient organ failure. Severe means persistent organ failure. So the patient has to be fit for GA. As soon as the patient is fit for general anesthesia, you can go ahead and remove the gallbladder because the risk of recurrence is high. Yeah.
So I think what you two put together, timing of ERCP and the timing of the cholecystectomy, what's the problem that you see there? Now you said it's gallstone pancreatitis and there's cholangitis going on. Yes, definitely you'll do an ERCP there. If it's gallstone pancreatitis, but there is persistent obstruction without cholangitis, you'll let the pancreatitis settle, you'll do the cholecystectomy, sorry, the ERCP later. And if it's gallstone pancreatitis, but the liver functions come down completely, there's no duct dilatation, you assume that the stone has passed. And if you need to be sure, you do the MRCP at a later date. But now you want to do the lab chole during that index admission. So then what's the problem you're going to face?
The diagnosis, whether it's actually a biliary pathology or.
We know that it's gallstone pancreatitis and we've made a diagnosis of gallstone pancreatitis. So what's the problem that you'll have?
The stone.
You might be doing a left chole in
An
a
obstructed system.
Yeah, well, not an obstructed system, obviously, because we know.
Yeah.
But it might be a floating
Floating stone.
that was
Floating
not
stone.
picked up. So is that going to be a problem?
Yes.
What's the problem?
We can
Is
cause
the
a.
stump going to blow out and leak in the lab chole?
No.
That's unlikely.
Unlikely. The stone would migrate down and because biliary flow system is now changed
They might
following the
have-
cholecystectomy.
Exactly. So they might have obstruction later.
Obstruction later.
And that's always something that you probably have to communicate with the patient. We are doing it on the risk of balances, no? Right? Like you said, it's unlikely that the stone would still be there if the ducts are not dilated, if the bilirubin has come down to normal. Now, MRCP, like we discussed, it's not available freely. And if you're going to do an MRCP to look for it, it's better to wait for the pancreatitis to settle completely and do it. So you can't in Sri Lanka do an MRCP during the same admission before you go for a lab chole. On the balance, if you wait, there's a 50% chance that someone is going to get a recurrent attack. Correct. Right? So you've got to tell them the checks and balances and say, yes, there is a chance that there's a stone, but it's low because we have done all these things. So we think that offering you the cholecystectomy now is probably the best way of sorting this out. Are you 100% sure? No.
So can an intraoperative cholecystectomy exclude?
Very good. That's the next thing, right? Because that whole problem is sorted if we do IOCs.
Now also these are patients who have wider cystic ducts or small stones. So at the time when you do the lab chole also another stone can fall.
Fast.
That you should tell to the patient. This is a possible scenario because later you might have to go and tell the patient now that stone in the CPG again, now you have developed pancreatitis and then you have to pre-intervene.
Yeah.
So
yeah.
So from the patients you get biliary colic only.
Yeah, that's very important. So what I want to come down to is that more than other instances, gallstone pancreatitis, if you're going to do the cholecystectomy during the index admission, that's actually an important indication to do a intraoperative cholangiectomy.
At least warn the patient, the patient that there's a possibility of having a stone. Because 5% of patients with normal ALP and complete liver functions can have floating CBD stones. So there is a chance. Otherwise, patient will come back to you and say, you told me after cholecystectomy, it's a complete cure. Now I'm having another stone. How come? So you have to tell the patient. If you think patient requires ERCP following lab chole, I would prefer to put a hemalock for the lab chole instead of liga clip. Because if you have to do immediate ERCP following lab chole, if you when you inject dye, there's a chance that the clip can widen and dislodge. Whereas hemalock, they don't.
It's not the pressure due to the bile buildup that causes the clip to get dislodged. It's our pressurized dye during the ERCP.
ERCP. Right. So what is the place for surgery? This is the last question. What is the place for surgery in acute pancreatitis? Acute pancreatitis per se, not for etiology.
Patients who are most of the time we manage with symptomatic management, but patients who are having severe acute pancreatitis, especially the necrotizing pancreatitis, which the necrosectomy might need it. That is the one indication. And patients who are having initial management, who are not getting better even after 1 week with the treatment, still, so we are thinking the necrosing segments are there and they are getting infected with high fever spikes, rising CRP.
shows negative. Spiking temperature, you're getting antibiotics. But still spiking temperature. What would you do next?
And actively can look for these gaseous bubbles, whether that might be suggestive of infections.
But not settling with antibiotics. What would you do?
So even with an antibiotic, if it is not settling, we have to intervene there. So minimally invasive procedures we have to prefer than the open one. We can go for a percutaneous drainage or laparoscopically or
You can do a CT scan and then go for percutaneous. Right. So sometimes it's not popular to see ultrasound guided. Because most of them are equipped with it. Then you can go for the CT guided drainage and it's also detailed correction. And then let's say patient correction is not still setting. Symptom problems are not coming down.
in that case, we may have to go for a repeated drainage in those patients. Like ideally, we can do it every 48 to 72 hours. We can take the patient and we can do it. Sometimes pigtails can get blocked. In that case, if the percutaneous method fails, we have to go for a open method, either by mainly a laparoscopically we can try retroperitoneal, depending on which part of the pancreas is affected. If it is a tail, we can go laterally, or if it is mainly the head, we can go anteriorly in laparoscopically. So if laparoscopically also difficult, then we have to do open drainage.
Most of the time, these collections can be percussion drained either from CT guided or ultrasound guided. And if the patient is spiking, you can re-image and see because most of these collections are communicating. If there are non-communicating collections, undrained collections, you can put multiple drains. And if patient still not settling, this is actually step-up approach. And then you can get the drains bigger, upsize it. Because we have 8 trench and 10 trench in the government sector. And we can't upsize more than that. And basically you're buying time and you try your best to delay your necrosectomy, if at all it is needed. Because if the necrosectomy, if you do it in early stage, you can damage before it gets walled off, WON, walled off necrosis. Then there's a chance of damaging the surrounding structures. So you're buying time until it gets walled off, and then do a repeat CT to make sure there are no pseudaneurysms around, and then go for necrosectomy. Because if you don't embolize the pseudaneurysm beforehand, do a necrosectomy, during necrosectomy, there will be a catastrophic bleeding. So I would definitely do a CT scan prior to necrosectomy. Right.
So to tell you about the surgical options, now me and Ritika, we worked in a center where there was like referral center for 11 million people in UK for HPP. For the 2 years, we have never seen a necrosectomy, right? Everything was interventional radiology. Even in Sri Lanka, where we get a reasonable number of referrals, still for the last 4 years, I have seen only one necrosectomy. So now surgery is uncommon, but when we were trainees or medical students, it was a common thing.
It has a high mortality.
Yes.
Necrosectomy per se has a very high mortality. So that's why we try our best to avoid it. If at all needed, delay. So most of the patients with defective necrosis patients can be managed with upsizing drains, multiple drains with antibiotics. But some patients, they need necrosectomy because of ongoing sepsis. The best thing is to do a minimal invasive necrosectomy. We can use the technique that is used by GU surgeons for PCNL and get them to put amplast sheets and then go and remove it. So these are minimal invasive necrosectomy. This is one of the open necrosectomy that we did.
So if you look at that necrosectomy, is this going to kill the patient? Look at the amount of tissue there. That amount of tissue, if you had that amount of necrosed tissue in your calf due to anterior tibial artery thrombosis or something like that, right? Or if you had it anywhere else in your subcutaneous tissue, that amount of necrotizing fasciitis, is that going to kill the patient? What's the problem with pancreatitis then? Why does pancreatitis kill the patient when you have that amount of necrotic tissue in you? The problem people believe is it's not just the necrosis, it's the infection that sets in on the necrosis. So what you are doing is you are removing the dead tissue that is going to get repeatedly infected. Right? And that is why, alternatively, if you have good interventional radiologists putting in multiple drains and making them wider and wider bore progressively is a good alternative. If we can't, we have to go for the necrosectomy. But if you can let all the infection there drain out, then they have a good chance of not going into the bad inflammatory response.
Right, any questions?
Well, on that side, any questions?
So with regards to surgery, in the case if there is a pseudocyst in a setting of acute pancreatitis, like when would we go for surgery in the case of the pseudocyst before there has to be a cutoff like 6 centimeters?
No, the pseudocyst, we call it a pseudocyst after 4 weeks. Before that, the acute fluid collections. Most of the acute fluid collections gets absorbed. Sometimes it remains forming a pseudocyst, right? So sometimes the walled-off necrosis can become a pseudocyst. More now, when we were medical students, when we were registrars, the cutoff was 6 centimeter. There is no size cutoff anymore. It is the symptoms. If the patient is symptomatic, we need to drain it. So anyway, when the size gets bigger, they are likely to have symptoms. But even if it's 10 centimeters, sometimes I manage without interventions if the patient is completely asymptomatic. So depends on whether it has a communication to the pancreatic duct, because almost all the pseudocysts have a connection to the pancreatic duct at the beginning and then they lose its connections. So if it has a connection, there's a chance of draining through the ampulla, ERCP and transpapillary drainage. Percutaneous drainage is not that good because it can cause uninfected cysts can become infected and also it can cause a fistula. I would say the best way to drain the system is to the closest viscera. Most of the time, the closest viscera is stomach. So that can be drained to the stomach using cyst gastrostomy, which can be done open, laparoscopic, or EUS. And EUS is the best because it is the minimally invasive.
Mnemonic is it needs to be ripe for drainage. RIPE. Either rupture, infection, pressure, or erosion. Okay. If you have none of those things, then that's fine. The commonest reason if it's not infected is that there's so much pressure on the stomach that completely not infected, not going to rupture, very stable, but it's so big that the patient can't eat anything. The moment they have a little bit of water, they have satiety because the stomach is completely cut. So that's pressure, right? It can erode into surrounding structures if it's infected. That's how you can get pseudoaneurysms and things if you let that happen. Infection we know of, right? The other one is, rupture. Sometimes patients with pseudocysts have acute flare-ups and they have a bit of ascites. That means there has been a leak somewhere and then they settle. And if that's happening over and over again with a otherwise asymptomatic non-infected pseudocyst, you also know that it's better to drain. All right. And the other reason we need to intervene in a pseudocyst is if we have a patient with acute pancreatitis, you find that there is a cyst in maybe the body on imaging, and 6 weeks later, it's still there, same size, and they keep having repeated episodes. Now, what's your problem? Yeah, you're not sure whether it's chicken or egg, whether the cyst is a pseudocyst that has resulted from the pancreatitis, or whether it's a cystic neoplasm of the pancreas, which is causing. In that case, are you going to do a cyst gastrostomy? So then you have to evaluate the cyst more, maybe with endoscopic ultrasound, something like that.
That is a situation I would do MRI pancreas to further characterize because pseudocysts, they don't have septate usually. It's a single cyst. So and some of the septates cannot be seen with CT only. So you can do MRI pancreas, and if it shows septate or suspicious features, then go ahead with EUS for further characterization.
Is this a necrosectomy?
Yeah, we can break for.
Yeah, you can show this first, no? This is amplats, no?
Yeah, amplats. So this is just like amplats sheet. Urology SR put the amplat sheets and then the necrosectomy. Unfortunately, it's very time consuming because you have to take small bites and again take it out. And if there's a pseudocyst in the cavity, it's a catastrophe. So you have to make sure that CT is done at least 24 to 48 hours before your necrosectomy.
We have a boy like that in ward now. No pseudocyst or CT, necrosectomy done. We actually had to go transgastric to cystgastrostomy approach and do the necrosectomy, take all the debris out. And he was recovering well and massive hematemesis around 5 days later. Second CT showed a pseudocyst, which was not there 2 weeks before.
That's happened to me also. And it's very important to differentiate the cystic neoplasm because sometimes we have come across patients they have done a cystgastrostomy for cystic neoplasm. I recently did a distal pancreatectomy, splenectomy, and cuff of stomach resection because solid pseudopapular neoplasm was drained to the stomach, thinking that it was a pseudocyst. So finally, you get a cavity like this. And then you insert the drain. Here's the cavity. Okay.
Questions?
Hmm? Any questions from the audience?
From anyone who's joining online?
We'll break for refreshments.
Yeah, audience? Yeah.
Why is that 6 centimeter cutoff for that pseudocyst intervention? No, not and the things are the mild acute pancreatitis. Do we need to give a stationary bolus to eat following maintenance, so we can skip that?
So the question is mild acute pancreatitis. Do you need to give a bolus? What do you think? Exactly. What is the fluid? So yeah, depending on the fluid status, no? So again, when you are answering that kind of question at the exam, you know that this is not now dependent on pancreatitis. No, this is dependent on the patient's fluid status. So the way I would answer that is by showing the examiner that I know the basic principles of fluid management. I'll probably say, I'm not sure about the diagnosis yet, so I have to start maintenance fluid. In addition to that, I will calculate the degree of dehydration, work out the fluid deficit, and give that. In addition to those two, the patient might have an ongoing loss because of recurrent retching and vomiting. So I will note an instruction in the BHT that vomiting losses should be replaced with maybe something that has potassium like heart. Then you have covered all. Right? Yeah. So always try and show that you know the principle behind. That's one issue that I think we have been communicating. We know the answer, right? Let's say someone asks you what to do in a patient who has gallstone pancreatitis and you are going to discharge the patient, what should you do before? You are immediately going to say, I'm going to do the cholecystics. But that's true, right? But you have only shown that you know the answer to that. You have not shown the examiner your thought process, right? While someone who's a bit slower starts with the standard sentence. My concerns are. And when the moment you say that, you have to get yourself into the show. What are the problems? My concerns are there's a 50% chance of recurrence. On the other hand, there might be a retained store. You talk about all that, and in the end, you say, after consulting with the patient and this, I'm going to offer this. You have come to the same place, but you use a couple of minutes to tell them your thinking process, and your thinking process gets more marks sometimes than the ultimate answer. Sometimes, even if the ultimate answer is wrong, you have got marks for your thinking process. While if you give the wrong answer, then you have a 0. Okay.
Yeah, nonsense or the mark, right? Don't think too much of outside the box also. Otherwise, that's not good, right? For exam is concerned. You look at a patient, guys, remember, it can kill the patient. It can kill the patient. Therefore, identify patients who are going to get bad. If your patient is not going to get better, abdominal pain continues, tachypnea, tachycardia, those are the patients who require severity assessment and treatment. Most of the patients, 85 to 90% of the patients develop mild acute pancreatitis, they go home by day 3 or 4. Only 15 to 10 to 15% of patients develop severe pancreatitis. So identification of those patients at an early stage is very important. As soon as you get the amylase level high, start hydrating the blood. Until that, continue maintenance.
Yeah, we'll have a couple of minutes for tea, and we were supposed to go to chronic pancreatitis at 10:30, maybe 10:35. We'll go to CP. All right, so we'll move on now to chronic pancreatitis. Again, we'll run in a question and answer session. Where's the mic now? Moving that way, yeah? Okay. So first of all, you have a set of reading materials here. Most of these are guidelines, and it might be useful if you can go through them at some point. I'll be referring to various parts of them during the presentation. So we'll go through the resources first. This is the British guideline 2018. This is from BMJ and this is downloadable. The American College of Gastroenterologists guideline is from 2020, right? This is also downloadable and it both talk about chronic pancreatitis. Then there was an international consensus guideline that was published in 2017 from Pancreatology. This is the oldest of the three, and the ACG guideline is a bit different to this in some areas. Regarding nutrition, there's a separate ESPEN guideline, right? And also, I don't think you'll need to know much about this, but there's an important trial called ESCAPE when it comes to comparing endoscopy with surgery in chronic pancreatitis. And also, there is a 2014 review article in BMJ, which is like a nice summary of most of those things, right? All these are freely available for download. And if you're going to start somewhere to get an account, this last BMJ article might be a good place to start, right? It's the newest and it talks about some of the other guidelines also. It references them there. But this is not a guideline. This is just a review. Okay. So we have again a case scenario. We have a 50-year-old bhikkhu from Anuradhapura who's been diabetic for 11 years. He has recently worsening, long-standing upper abdominal pain, has been treated for gastritis in the past, right? He has bloating and loose stools, and subjectively, he says that he has loss of weight and loss of appetite. This is usually not your casualty admission patient. This is your clinic patient. And therefore, this is also your observed history taking patient, not an emergency like acute pancreatitis. So here, more than your acute resuscitation, we'll need to focus on what information we need to gather, what our concerns here are, right? So going with that, we'll start with what concerns you want to find answers to in your history and examination next. Can you, if you want, you can take a moment, think about it and answer. What concerns you want to find answers to in history and examination in this particular case?
How long these symptoms have been going on for, a number of previous episodes, and how many of them had required admissions before, and how each of those episodes have been treated. Then also to look for causes, alcohol, just like acute pancreatitis. Then to look for complications. Now he already has diabetes, features of exocrine failure, endocrine failure.
Okay, good. What else? We'll move on to the next person.
So based on the given scenario, my major concern, the history, I would like to identify I'm dealing with the benign causes or malignant causes, because there's a loss of appetite and loss of weight is most significant features. So in the my targeted history, I would like to establish the present and complaining of pain. So the characteristic of pain and pain details. And if the patient who is having a previous history of pain details, as well as there was a history suggestive of loose stools. So the lower GI symptoms also I want to measure in these conditions. And with the relevant history, I would like to I will come for the differential diagnosis such as benign causes of chronic pancreatitis. At the same time, I would like to consider the malignant causes aspect of low GI, but it can be excluded with the history.
What malignant causes are you most concerned about?
This patient's history, there's an upper abdominal pain and there is no loose stools. So the most upper GI and lower symptom, both symptoms is both system also involved in this given scenario, sir. So my malignant, I will target I will like to target in the both upper GI as well as the lower GI.
Can you be more specific? Are you worried about esophageal cancer?
No, gastric.
Right.
Gastric.
Okay, so that's a good starting point. So I think just like in the previous acute pancreatitis scenario also, here one of the most important things is the differential diagnosis to start with. So don't stampede along the pancreatitis pathway, right? Any 50-year-old with dyspeptic symptoms and recent loss of weight is a red flag for upper GI endoscopy, as you know. So this might be the first presentation of a gastric CA. What are the other malignancies that are notorious for causing loss of appetite?
Cholangiocarcinoma, sir, but
Not common. 3 malignancies we say are now thyroid cancer, you're not going to talk about loss of appetite, no? Right? Loss of weight, colorectal cancer, we don't talk about that. What are the 3 malignancies known to be associated with
pancreatic and cecal cancer?
Pancreatic, gastric, or primaries or secondaries in the liver. Those are the 3 things where we worry about loss of weight and loss of appetite more than other things. So the moment you get upper abdominal pain, right? Gastritis, so-called in quotation marks, and that you have to worry about those 3, right? So the first part is having a differential diagnosis and asking, just like in the previous case, a history for all of those. Is the priest on NSAIDs? Is a diabetic? Is he on aspirin? Right? Do we have any risk factors for ulcers? Right? If you are thinking about ulcers or malignancy, are there any features of occult or overt GI bleeding? Any other features of malignancy like obstruction, things like that? Right? Metastatic features. You need to go through all that. Chronic pancreatitis is just one of many. So if this is your long case, you will get marks if you go along the pancreatitis pathway, but you certainly will get a really good mark if you go along the pancreatitis pathway after having logically excluded the other causes, right? Sometimes your patient might just be having loss of appetite pain, not knowing that they have pancreatitis, right? And your history might just be how to analyze an upper abdominal pain with loss of appetite, loss of weight. It's only once you go into the discussion and they give you the investigation findings, will you be able to properly go along the pancreatitis pathway. Okay? So you'll have to be very broad there. So those are one set of concerns that you have. Let's say that you go through those and you've excluded pretty much all the other causes of loss of appetite, loss of weight, and upper abdominal pain. Then what else do you want to have answers to? You think this is chronic pancreatitis, no?
So the chronic pancreatitis is a disease of pain. I want to more analyze about the pain, sir. Whether how it is interfere with his day-to-day activity, and whether his patient is dependent on any opioids or any analgesics. And
how do you want, can you say something more about how you want to know whether it's affecting their day-to-day activity? He's a priest. He's 50 years old. What do you want to know?
How frequent he is visiting to the hospital, and what about the hospital stays?
Okay.
6 months, how many episodes like?
Right.
And I want to assess as the pain is there for a long time. Is there any recent change of
symptoms. Good. Pain per se, is it directly through and through pain to epigastric to backward, or any new onset of symptoms like obstructive jaundice or anything?
Okay, right.
Recent changes.
Yeah, anything else? Any more basic things like that? The previous person also talked about it. Severity, how are you going to assess?
Severity of the pain.
Are you going to say it's mild, moderate, or severe?
So we can assess with the pain scales.
Why is it important?
Depending on the pain scale, we can treat the pain ladder according to the WHO pain ladder. We can consider the
that's
sort
true.
of drug is needed.
More than that,
and we can compare with the improvement.
Exactly. This is a chronic pain. No? So when you come to management of chronic pain, you have to bring the patient into clinic several times. The patient will be visiting you monthly. You need to know those three things you mentioned. You need to know how much this is affecting their day-to-day activities, how many days per month or per week that they are missing their day-to-day activities because of this. It might be hospitalizations, or it might be that they had to take strong analgesics and they couldn't do anything that day. You need to have a pain diary where those days are mentioned. Then you need to know the severity of the pain. On the worst days, what is it on a scale of 1 to 10? So they need to be introduced to the visual analog pain score and need to get an idea there. And also, like you said, because we are worried about complications, whether there are any recent changes in the nature of the pain. You need to know all these things because in every clinic visit with your various interventions, these are the things you are monitoring for to see whether these things are improving. So chronic pancreatitis patients, unless you establish a pain score, know the number of days of work they are missing, you can't follow them up in clinic. Right? So these are important things you need to know. Okay, we'll move on. What else do you want to know in history?
I want to assess the other parts of the history as well. Patient has been having loss of weight. So assess the amount of weight he has lost during which period, and he has been complaining of loose stools and bloating as well. So assess those components of the history.
What do you want to assess in loose stools in the history?
The frequency.
Right.
And whether the patient is passing blood as well, passage of blood rectally, and whether associated alteration of bowel habits, whether change of bowel habits recently or patient has been having that for a long duration, and whether patient is having steatorrhea as well.
Can you describe steatorrhea?
The passage of stool with has a consistency of fatty and very difficult to flush, and which float after passage, and that may indicate complication of indicate pancreatic insufficiency, and also
yeah, good. I'm happy you didn't use the word pale stools there. Because remember, you have two kinds of steatorrhea. You have biliary steatorrhea and you have pancreatic steatorrhea. Biliary steatorrhea is where you have obstructive jaundice and no bile, no emulsification, and therefore you have frothy stools. Since there's no bile, stools is pale. In pancreatic steatorrhea, bile is going, but you don't have lipase. So there you don't have pale stools, but it's going to be, like you said, frothy, difficult to flush, right? So you're looking for that. What else? We'll move on. Next one. What are the other concerns you have in the history examination? Anything you can think of?
Worsening of diabetes mellitus.
Okay, yes, you probably need to know about his diabetes also, no? What kind of diabetes would he be having if you think this is pancreatitis? What are the types of diabetes we know about?
Type 1.
Type 1, type 2, 3, 4. Which type is it usually in pancreatitis? Anyone? Now, the normal insulin dependent diabetes we know of is?
It's brittle diabetes, sir.
Yeah, it's brittle. Well, brittle diabetes is usually what we describe after pancreatectomies, right? Type of diabetes, what do you get? Pancreatic diabetes is which type? We call it a type 3 diabetes, no? Type 1 is 3C, no? Yes. It's a type 1 diabetes is due to insulin secretion being affected, but it's not due to a pancreatic diabetes overall goes in type 3. Yeah. What other concerns do you have apart from the diabetes? So remember, if you have a diabetic patient, like you said, assessment of diabetes means you have to look for the micro and macrovascular complications, right? That needs to be part of your history and examination. What else?
I think you have, I think for 11 this slide, you have complications. But you are going to image this patient at one point. Very important to know what drugs the patient.
Thank you, sir.
So there is a diabetic for 11 years. So it's very important to know the complications of diabetes because you are going to image this patient at one point. And if you ask in the history that without asking just diabetes, how is the control? And what are you on? Are you on insulin? Are you taking metformin? Because that is going to be very important for your management. And in the discussion, if you say, so I will do a CT, my patient is having diabetes for 11 years, therefore I will specifically look into creatinine and also make sure that the patient is not on metformin. And those things, that means you're answering for that patient without just blurting out what you know about chronic pancreatitis. So that candidate will get more marks than just a candidate who will just say, I will do a CT.
Yeah, whenever you have a patient with diabetes in your long case, don't look at that as a nuisance that you have to get through. Look at that as an opportunity. You have within 1 or 2 minutes, you can take enough in the history and examination to talk about so many dimensions. You have a patient who is going for an APR, you find that they have diabetes, check the femoral pulses, right? What if you are going to dissect in the pelvis where there's a blocked artery? You pick up things, right? So always look at diabetes as an opportunity where you can spend a couple of minutes and show that you know more about this than just that particular condition, right? Especially in chronic pancreatitis. Go to town about the diabetes, right? Okay. Anything else?
So if there have been previous episodes of hospital admissions, I would go through the previous records and check what were the investigations have been done and any previous amylases level that would support the presence of previous episodes of acute pancreatitis, which has been evolved into chronic pancreatitis. Or this is to start with chronic pancreatitis and because of the long-standing history, possible complications. Now we have already endocrine, exocrine, and in the process and changes of supporting features of pancreatic malignancies, the outset of chronic pancreatitis, and the support because of this would be a multidisciplinary management. So the support that he is having because he's a bhikkhu and level of support and understanding about the disease condition. Yeah, those sort of stuff again back into the history.
So what about him being a priest might be problematic in your management?
When it comes to the nutrition optimization, that would be a major role in chronic pancreatitis. And maybe he is having limitations in when it comes to the nutrition.
Yeah, that's a good point, no? Because their meal times are very different. So you need to know whether their willing to adjust their meal times to be compliant with your treatment, whether they have had a nutritionist to help them with that, right? So all these things add new dimensions. Okay,
And
next.
also asking whether the patient is taking alcohol is also a big problem.
Yeah. Because I mean, Arishta is about 20% alcohol, right? And you can be taking all sorts of Ayurvedic medications, which can also be etiological factors for chronic pancreatitis. So those are also there. Anything else? We've asked a few things in history. Examination, what would you want to check specifically?
It's general examination like emaciation and the nutritional.
So what are you going to do in general examination to assess nutrition?
Whether he's well looking or emaciated or
Just general appearance. What else?
weight.
Yes.
Then epigastric pain, whether the patient is having epigastric pain.
Yeah. We'll talk about your nutrition first. In your general assessment, you said that you want to see whether they are ill looking or well looking, whether they are emaciated or not, but and weight. What else? We'll finish one thing first, nutrition. Can you think of anything else?
No, sir.
Next one.
So the nutritional parameters like circumferential length of the arm and skin fold thickness.
Good.
And those
Yeah.
parameters.
So a nutritional assessment examination is not just wasting and weight. If you are in your examination, you need to ask whether the patient's BMI has been assessed. Okay. So in your examination, there is also anthropometry. Anthropometry means things like height, weight, and BMI, mid-arm, skin fold, any other assessments that we make in examination to check whether muscle mass is adequate. Anything else?
So to check for other muscle power.
We check grip strength, muscle power, right? Whether muscles are wasted, right? All these things are important.
Equal ones like, angular stomatitis, glossitis,
Yeah.
ankle edema, all these are important.
So there's a lot in general examination that we tend to miss out on in our nutritional assessment. If we just go with wasted and weight. Okay. Macronutrients, micronutrients, so many things to look for. What are the particular micronutrient deficiencies that you want to check for? Next one.
Water the lipid absorbent vitamins like vitamin K, A, D, E.
Yep.
And
So how are you going to assess them in your examination?
so vitamin K, I can look for any ecchymotic patches, and the other vitamins wise, maybe again angular stomatitis.
What vitamin deficiency are you looking for there?
Vitamin A.
Okay.
And also vision.
Yeah. So remember, obstructive jaundice, you have an acute loss of fat absorption ability. So you're only worried about the vitamin that has no stores in the body, which is vitamin K. But this is not acute. This is a patient who may very well have had long-standing malabsorption. Here, you have to look for problems with other fat-soluble vitamins also. So A, like you said, things like night blindness might be there. D?
Bone pains.
Yeah, bone pain, osteoporosis, maybe fractures. You'll need to ask whether they have had episodes of backache associated with trivial trauma, fractures, things like that. All this might be due to vitamin D. Yeah. Then E is difficult to assess. right? Vitamin K, again, you'll have to look for coagulopathies also. All the micronutrients you have to look for. Edema is macronutrient deficiency, right? Okay, so nutritional assessment. What else? What are the other areas you want to focus on? Next one.
So is it during examination?
Yeah, history or examination.
I would be concerned about the level of diabetes control of the patient.
Good.
So
Yeah, so we are talking about diabetes again, no? Yeah.
yes,
Control, compliance.
and in examination point of view, I'll be looking for features of microvascular disease as well as macrovascular. So
okay,
pulse examination and diabetic dermopathy, any.
Yeah, so that's all focusing on the diabetes.
Diabetes.
So now areas we have talked about so far, we have talked about pain and the detail and depth you need to go into about that. We talked about diabetes and the endocrine failure and the detail and depth you need to go into about that. Exocrine failure, we've talked about the detail and depth you need to go into in that. So now these are the various chunks, right? Exocrine failure, endocrine failure, pain. You have talked about those three areas. Any other areas that you can think of? That you need to find information about? Anyone else? Palind? Yeah.
There may be features suggestive of obstructive jaundice.
Okay, why?
Looking for actress by compressing distal common bile duct by the head of the pancreas.
Yeah, so not only due to malignancy, right? Even the in chronic pancreatitis, calculi, inflammatory process, all that. So in addition to these three chunks we talked about, exocrine failure, endocrine failure, and pain, there can be various local complications that occur due to the chronic pancreatitis process also, and you'll need to look for those. And if the inflammation is in the head, one of the common ones is biliary obstruction. Yeah.
Again, gastric outlet obstruction.
Yeah, gastric outlet obstruction. Yeah, we'll move on. Anyone else? What else do you want to look for?
So if the chronic pancreatitis is long-standing, there is a risk of this patient developing a pancreatic malignancy. So I will think in line of.
What are you going to look for specifically there to see whether this is just chronic pancreatitis or if there's a new onset malignancy going on? Again, it's probably changes, no, in the history, sudden change, sudden loss of appetite, sudden loss of weight, in sudden increase in pain. Those are the things you look for. Yeah.
Patient with a good control, now the control has gone
Suddenly going bad.
Suddenly going bad. Sudden onset, unexplained backache, non-traumatic.
We really don't know why that issue Malik said happens, why there's an association between diabetes and pancreatic cancer. We don't know what comes before or after, but we certainly know there's an association, right? That people with people without chronic pancreatitis, new only on diagnosed diabetics, you find that they have a pancreatic tumor. We don't know why.
So if a patient with chronic pancreatitis complains of loss of weight, what are the possibilities? So
It could be direct consequence of pancreatitis as a nutritional deficiency. Oh,
you mean nutritional? Okay, it could be a exocrine failure.
Exocrine failure.
This is a loss of weight. So patient complains of weight. One is nutritional. Anything else?
Or it could be metastatic.
It could be a pancreatic cancer in the background of chronic pancreatitis. Anything else?
It could be endocrine failure due to diabetes.
So those are the three. And also fear of food. Some people, those who have pain, they don't eat. We talk to them, so fear of food also can cause loss of weight. So these are the things, and it can be a combination of one or two as well. So it's very important to take the history and examine the patient and see which one it is. And at one point you have to exclude malignancies.
So the one thing that was not mentioned by you so far, which I wanted, obviously that's the thing that we don't talk about commonly, is etiology. So you talked about all the possible complications and things like that, but we need to do a proper etiological assessment in chronic pancreatitis also, right? So it's a bit different from the mnemonic that you have in acute pancreatitis. Some of the things that cause acute pancreatitis don't cause chronic pancreatitis. No, you need to be an idiot to be bitten by scorpions over and over again. No, right? So those things obviously don't, but some things do. But the chronic pancreatitis etiologies are a bit different. So some of them you'll find in common, but some of them, like smoking, don't cause acute pancreatitis, but cause only chronic pancreatitis. So there is a kind of a mnemonic which you will find in those resources, which you can read about and use in your histories, right? There is one called the TIGA-O, that's a mnemonic. T stands for toxic and metabolic causes. I for idiopathic, G for genetic, A for autoimmune, R for recurrent, because if you have acute pancreatitis, that can damage the duct so much that you can get chronic pancreatitis after that, because there's fibrosis and things like that. And O is because of drainage problems in the duct due to tumors, divisum, sphincter 4D problems and things like that. So TIGA-O is one way. There's another one called Mannheim.
Tumor means not pancreatic cancer. Because pancreatic cancer will not give us to acute pancreatitis that many times to develop chronic pancreatitis. It's a patient who develops pancreatic ductal adenocarcinoma in the background of chronic pancreatitis. Pancreatic cancer, ductal adenocarcinoma cannot be the cause for chronic pancreatitis because patient will be 6 feet under before that.
Yeah.
So it cannot be very important.
Yeah. Here it's usually we do something for tumor and that causes strictures. That can also happen.
Yes.
So this is one way. There's another thing called Mannheim. That's also a mnemonic. Where else do you have Mannheim? This is a mnemonic, Mannheim. Where else do you have Mannheim in abdomen? Have you heard of the peritonitis score? The Mannheim peritonitis score for prognosis in peritonitis? No. So read about that also. But these are both two ways that you will find in those guidelines of assessing the etiological factors. They both have the same thing. I'm just putting both here so that you can go through and work out which one you find more useful. But this is both for etiological assessment.
One more thing, recurrent acute pancreatitis is known to cause chronic pancreatitis. But having said that, ghost stone pancreatitis does not cause chronic pancreatitis. If that happens due to recurrent ghost stone pancreatitis, that's a medical negligence. Right? So don't say ghost stone as cause to chronic pancreatitis. Theoretically, recurrent acute pancreatitis can cause chronic pancreatitis. Ghost stone can cause chronic pancreatitis. Therefore, ghost stone can be of course, we cannot use like that. If a patient needs to get recurrent acute ghost stone pancreatitis and develop chronic pancreatitis, that's I think medical negligence.
Yeah. Okay. So these are the basic investigations done on this patient. Right? Can one of you just comment about what you think about this?
Basic investigations, he's not having anemia. Hemoglobin is marginally on the lower side.
Marginally on the lower side is anemia. Definition of anemia is what?
Hemoglobin less than.
Below the lower range, margin of the range, no?
So he is
Okay.
marginally anemic. His inflammatory markers are not elevated. His serum amylase is on the normal level, but we can't comment actually about it because this could be a chronic pancreatitis with pancreatic atrophy.
Okay.
And INR is on the 1.4, which is quite elevated, but to the marginal level of the upper cutoff. So he might have a coexisting coagulopathic problems.
Why?
Because there could be a long-standing biliary obstruction because of the.
Again, no, that's what I wanted to highlight again. You don't need biliary obstruction because here you have no lipase. So if you have, if you have fat soluble vitamin deficiency due to lipase absence, you don't need biliary obstruction to get a slightly high INR. Okay.
Okay.
What else?
Abdomen is on the lower side because because of his long-standing history of this abdominal pain and everything. He might be malnourished because of multiple factors. Creatinine also marginally on the higher side because normal cutoff is around 1.1. He's having a history of diabetes for more than 11 years. So we never know whether he's having a diabetic nephropathy on the background.
Good. Yeah.
And electrolytes, no derangements. It's normal, sodium and potassium.
Anything else? Okay. Next one. Anything else abnormal that you see here?
CRP is high, sir, 37. Platelet, there is a thrombocytosis as well.
Why is there a thrombocytosis? Anyone? So again, that's a marker of long-standing inflammation, right? Thrombocytosis occurs in two surgically important conditions. One, well, splenectomies, and the other is long-standing chronic problems like chronic inflammation or slow bleeding. You have slow bleeds into the GI tract, you get a thrombocytosis, right? You have long-standing chronic inflammation, you get thrombocytosis, right? Okay. So apart from these investigations, what more would you want if you're going to run a panel of investigations on this patient now?
To see the diabetic control, I will do fasting blood sugar, HbA1c level. And then I will do further cardiac assessment investigation like ECG, echocardiogram.
Okay, so you have done diabetic assessment, cardiac assessment. Go on.
Lipid profile.
Right. Okay. Again, you are looking for cardiovascular risk factors. Okay. Next one. Anything else you can think of? So what's important again here is structure, right? When you ask a question like that, go back to your original structure. What are the problems you need to find answers to here? We went through them in the history and examination once. Same again for the investigations. Okay. You have to look for etiology. You have to assess exocrine failure. You have to assess endocrine failure, pain, local complications, whether there's any malignancy or not. So if you are asked about investigations, again, those are the areas. And in each of those areas, there are various things. So what you are talking about is inside endocrine failure, inside diabetes, you are talking about looking for the macrovascular complications of diabetes, and the other risk factors. That's a very small area. Yes, those are important, but you have to step out and see the broad classification. So in chronic pancreatitis, always have those 6 areas at the top of your head. You are going to look for those areas, right? Those structures are really important. As long as you have that structure in your head, it's much easier to take the history, do the examination, and investigate the patient also, because those are the 6 problems that you are trying to find answers to. And you came up with all of them, apart from maybe etiology to a degree, you came up with all of them, right? So investigations also, you have to complete investigations to do those, right? So to diagnose chronic pancreatitis, what are the things that you want to do? What investigations do you want to do to diagnose?
And go with the imaging.
Yes. What imaging?
CT.
More detail?
CCT.
CCT? More detail?
Pancreatic protocol.
CCT? Abdomen? Only, or do you want chest and abdomen also?
Only abdomen.
Yeah. And then if you find a malignancy, you have to do CT chest again, no? So if you're going for CCT, go for CT chest and abdomen, but request a pancreatic protocol, right? Do you know about pancreatic protocol? Do they need to know about pancreatic protocol, Malik? Suchinta? Details? No, I don't think you need to. It's basically timings, right? So at least, do you know how to do a portal venous phase separately and the timing difference between venous phase and portal venous phase in a CT? Yes. Okay. So just ask for CT chest and abdomen with pancreatic protocol, right? Yeah. So anyone else? Any other suggestions? We'll just brainstorm, pass the mic along. Any other things that you want to do to diagnose?
The exocrine failure, we have to do the fecal elastase to confirm.
Okay, good. Exocrine failure, fecal elastase. Next one.
Ductal abnormalities, I would do MRCP.
You want to do an MRCP for ductal abnormalities. Okay, good. Next one.
So initially, can as a simple investigation first, I can do X-ray abdomen as well, and
Good.
can identify calcifications.
Calcifications.
That's investigation.
Okay, good.
Endoscopic ultrasound is good.
Yes. What are you looking for in the endoscopic ultrasound?
Look for any duct dilatation, any atrophy, pancreatic atrophy.
So can't we see those with CT and MRI?
So if the diagnosis is inconclusive, we can go for endoscopic ultrasound. The CT is initial.
So if you think it's chronic pancreatitis, but CT and MRI are normal?
It's inconclusive, we can go for endoscopic ultrasound.
Okay. Right. What else?
Just other complication like osteopenia and osteoporosis, we can X-ray the other bones.
Okay, good.
Regarding that EUS, if there is any suspicious features in the cystic lesions, we can do aspiration and cytology.
Yeah.
And other.
Do we need to do histology or cytology in any other cases in US in chronic pancreatitis? Yes or no? Suspicious features? Yes. Anything else? Yeah, we'll pass the mic on to that side now. Did you answer? Yeah. Etiologies? Yeah. Okay. Now we're talking about diagnosis here. So what do we need to do to diagnose? Is CT enough? You said MRI, right? MRCP. Are those enough? Any other investigations? Do you need to do all these? No.
Can I ask you questions? Now, you said X-ray abdomen. If X-ray abdomen shows pancreatic calcification, will you not do other investigations, or do you still have to do a CT and MRI? So I know MRI. You have to do it because you can't see anomaly. The one who said CT, what are the things in the CT that you want to check for in chronic pancreatitis? Apart from what are the things that you would anticipate? Hmm? Local complications. No, to say that we are talking about diagnosis. We are talking about diagnosis. What are the things in the CT with regards to diagnosis? Now, see, now chronic pancreatitis has morphological changes that only you can diagnose in your imaging. So, what morphological changes would you anticipate in the CT scan?
Calcification would be there.
Yes, calcification. What else? If there's obstructed calculi, what will you see?
The duct dilatation
Duct
would be
dilatation
there.
or stricture or whatever duct dilatation. What else? With regards to calcification of stone, what else you want to know?
The density of the
Density of it. Yes, density of it. That is also important for management. And the burden, calcification burden, whether it's a single small calcification specules or large calculi, whether they are the main duct, the distribution and the density, and the other is duct dilatation, the other morphological change is pancreatic atrophy. All these are important. So without just saying a CT scan, you have to say contrast enhanced CT scan pancreatic abdomen pancreatic protocol. There, I would anticipate these morphological changes. That would be a complete answer rather than just saying a CT scan. Right? So try and when you get the chance, try and show your knowledge maximum. This is part 2 candidates. So otherwise, that is the time for you to show that knowledge. Otherwise, you will not get a chance to show that part of the that part of your knowledge. Okay. Right.
So,
in chronic pancreatitis, chronic pancreatitis has actually 3 stages. One is end stage, where the extracrine endocrine failure. Then the established chronic pancreatitis. We know there's a diagnosis because of the morphological changes. Then the other one is a very early. So very early, where these are the patients who have recurrent acute pancreatitis with no cause. Actually, they are recurrent acute and chronic pancreatitis. There, the US is very, very important. So US can up things that are not seen in CTO MRI.
so just a few images here. What CT is this? Anyone? Where's the mic?
NCC.
Yeah, this is a non-contrast CT. So the first step you do is a non-contrast CT because you are going to look for what? What are you looking for?
Any calcification?
Calcification. That's the first thing. So you can see the calcifications. Why aren't they all in the same place? Why do you have several cuts? Because the pancreas is not a transverse organ. No, the head lies low, the tail lies higher. So you see the tail in higher cuts and you see the head in the lower cuts. So you see widespread calcifications here, right? Then once that is done, you would probably want to go to CECT. Right? And there again, you can see a normal pancreas is much bulkier than this. So with the CECT, you can get an idea about the size of the parenchyma. The parenchyma is much thicker than this usually. So now you know that there are calcifications and you know that there is parenchymal atrophy. And the third thing that Dr. Malik was talking about, right here in the middle, this is the duct. And you have a dilated duct. So you have duct dilatation and parenchymal atrophy and calcifications. Now you have a diagnosis. Press the mic. So what's the gold standard? We'll pass the mic on to that side now. What's the gold standard for diagnosis of chronic pancreatitis? Is it the CT? Is it the MRCP? Is it the endoscopic ultrasound? Is it the the features of exocrine failure, endocrine failure, what's the gold standard?
Calcification in the pancreas?
No, that is present only in about 50 to 70% of the time. This would be an MCQ question, I suppose. What's your gold standard? Now, for acute pancreatitis, we have diagnostic criteria, right? And we can work out that someone has acute pancreatitis if they have 2 out of 3. Chronic pancreatitis, what's the gold standard? Is it the CT? Is it the MRCP? US? What? Next one?
It's a CT.
CT. CT, 70% to 80% sensitivity. That's because chronic pancreatitis needs to have gone on for quite a long time for you to get these large calcifications and the atrophy. So what am I trying to get at? What would the ultimate diagnosis be?
Establish the exocrine combination.
Even before that. Chronic pancreatitis starts even before the exocrine and endocrine failure occurs. So for at least, so there's one online response which is correct. It is biopsy. Okay. Histology is the gold standard. You have to show chronic inflammatory changes. But you can't get that most of the time. So we have all these other tests which we use as surrogates. And we don't need it most of the time either. We don't need it most of the time because unless patients have exocrine failure, endocrine failure or pain, we don't need to treat it. No? Right? So just diagnosing is pointless. But the gold standard is histology. So when are you going to use all these things we talked about? When are you going to use EUS? When are you going to use MRCP? When are you going to use CT? Next one.
Depend on the facilities. The CCT.
Depending on, one thing is facilities. What else? What is your first line investigation usually? What would your go-to investigation be? MRI, CT, EUS, what?
CT.
Yeah, CT is the first line investigation, right? CT, pancreatic protocol with a non-contrast imaging also. That gives you enough. If there are diagnostic difficulties on CCT, that's when you would go for the next step. What would the next step be?
MRCP.
Yeah. Now, overseas, it is not just a normal MRCP. We do secretin stimulated MRCPs. That is supposed to give us the best idea about the duct. Because that fills the duct up more. Right? But next step would be MRCP. And EUS comes even later on. The advantages of EUS is that you can closely image, and if necessary, you can take a tissue diagnosis also. Right? That's where there's an advantage. Okay, so this is one of the suggested workups. Again, this is just going to be an information overload for you if you just read this and try to memorize it. Practically, you stop at the cross-sectional imaging, which is the CT. You don't go beyond that in our setting. But you'll probably need to know the place of various other imaging modalities like secretin enhanced MRCP, EUS, and how to perform various exocrine tests. The common ones, like you said, are stool elastase. We can also check stool fat percentage. That's also an easier thing to do. Is elastase available in Sri Lanka? Yeah. Okay. So these are, in the end, the aspects of management that we need to have in mind. Right? And most of the guidelines that we talk about these various aspects and how to deal with them. Right? So we'll go about them one by one. With pain management, How do you assess pain? We have already talked about. We've talked about the visual analog pain score and days missed in work and whether the pain is getting worse, things like that. Right? So once we know the pain, what do we do next? Who has the mic? What do we go for? Do we go for drug treatment? Do we go for invasive methods first?
We can start the managing patient with multidisciplinary team approach.
Good.
Where both the application of pharmacological, non-pharmacological and surgical management can be applied on the patient. Initially we can start with the pharmacological management first. Meanwhile, assessing the patient's response to the treatment. And according to that, we can tailor the further management after discussing with the team that we are having.
Right. So who is involved in your multidisciplinary team?
There has been a surgeon who is treating, as well as a physician, as well as
How do you want the physician involved?
because the patient is having diabetes as well. In that case,
Good.
we have
And some of the drugs that you're giving might affect the diabetic management, right? They might have renal issues, things like that. So you need to worry about that. Yeah. What else?
then anesthetist has to be there who is managing the pain.
Yeah. So in Sri Lanka, it's the anesthetists who usually manage the pain. But in other countries, sometimes there are separate pain teams. There are pain physicians. Okay. But yes, there must be someone who is managing the pain. Good. What else?
The nutritionist has to be there to advise on the nutritional state. Then nursing care has to be given to the patient. Meanwhile, supporting other organs as well.
Right.
And
So, okay, we'll talk about the drugs. What medications do you want to start with?
yeah, usually as it's we can start with according to the WHO pain ladder. Starting initially, NSAIDs more like unlike we give good response with the chronic pancreatitis. So we may start with adjuncts of the pain management as well as a weak opioids can be started at the beginning. If severe pain, we can start.
Give me an example.
Codeine related analgesics. And tramadol, oral weak opiates such as tramadol can be given. The same adjunct can be given apart from the opioids and the NSAIDs such as gabapentin and antidepressants and as well as TCAs can be given to manage the chronic pain in such patient because most of them are associated with the neuropathic pain than the inflammatory pain. Apart from that, we can manage the non-pharmacological management to manage the pain such as psychological support as well as TENS.
Yeah, so not commonly done, but yeah, okay, good. So your approach was good. You wanted a multidisciplinary team and you started with simple analgesics, weak opioids. So you're going up on the chronic pain WHO ladder, isn't it? You're going with low intensity drugs and slowly increasing, right? Good. So
What are the reasons for pain in
yeah.
There can be pains can be associated with the anatomy, alteration of the anatomy such as increased ductal pressure, increased parenchymal pressure. Apart from that, altered neurological functions with a hypersensitivity of the nerve endings and abnormal celiac associated celiac plexus inflammation. Apart from that, retroperitoneal fibrosis. Apart from that, perception of the patient as well as the alteration from the higher centers also can be affected.
Yeah, good. So we talked about obstruction to the duct causing what we term as ductal hypertension. We talked about neuropathic and chronic fibrosis. Then there's the affective component. Anything else apart from the affective component, the neuropathy and the ductal hypertension?
Implications of the pancreatitis such as pseudocyst formation.
Yes.
And external compressions. And
sometimes just ongoing inflammation. You can have a large inflammatory mass, right? Especially like if the CRP is a bit high, white cell count is a bit high, there might be ongoing inflammation. So the point Dr. Malik was trying to get to is what we will be circling back to next. Working out the possible cause of the pain is very important before you start drugs, right? Because there are some easily treatable causes which don't require long-term analgesics. So you are going to start patients on simple analgesics if you can't fix any causes. So you fix the fixable causes and then you go on to analgesics. That's why there's always this debate on whether you should go with invasive treatment or drugs first. Yes.
Addition, whether the patient is endoscopic or surgical treatment, we need to know the possible incursion for the pain. Apart from what you mentioned, you have always mentioned about the avoidance of precipitants like alcohol, smoking, those things. And you said psychological support, very good, because pain cannot be cured. They have to tolerate the pain to a certain extent. So you have to educate them with regard to that. And also avoidance of precipitants. You can't just say stop smoke, stop alcohol, because most of them are addicted to it. So you have to refer them to support groups, maybe refer to psychiatrists and give nicotine replacement, something like that. So you have to look into that in detail. Otherwise, whatever you do, ER, CPO, surgery, if you don't avoid risk factors, precipitants, pain is going to continue. That is also very important. So overall management, pharmacological, non-pharmacological.
Yeah. So the recommended drug classes, I think you mentioned the simple analgesics, opioid analgesics. We avoid NSAIDs, but adjuncts include things like GABA stimulants as well as antidepressants, tricyclic antidepressants as well as SSRIs. Those have been shown to improve the affective component and they help. So all these adjuncts are evidence-based and you can start them and try, right? The issue of invasive treatment or drugs first, after the multidisciplinary discussion, usually we start with simple analgesics first, like you said. But like Dr. Malik mentioned, controlling the etiological factors is paramount. Stopping drinking, stopping alcohol. Generally, they recommend don't go for interventions if the patient doesn't stop the precipitating factor. If they continue to smoke, if they continue to drink, you are not going to do any invasive procedures on them. Right? You stop at that point, you go only with the medications. You are not going to escalate unless they correct that lifestyle factor. Okay? And
enzyme, does it really pay?
yeah, so that's another important question that I've put up there. Can enzyme supplementation improve abdominal pain? Next one.
I'm sure, sir.
Yeah.
So they will have, due to steroid, they can have abdominal bloating and other symptoms. So the enzyme supplementation will help with that.
Well, so that was the belief, right? That bloating and things like that. And also, like Dr. Malik mentioned, avoidance. That patients don't eat because they get bloating and things. And because of that, we were told that. Now, there have been lots of trials about this, right? Overall, some trials show that enzyme supplementation also can help, but overall, it is not in a guideline as recommendation, right? So enzyme supplements purely to improve pain is not recommended. You can start them for other reasons, but if someone has no exocrine deficiency at all, but they have pain, there's no point in adding enzyme supplements for pain control, right? Yes, bloating and all that, yeah, obviously that's there, but that's you're giving it to improve the exocrine failure, not for pain. Okay. What about antioxidants? Have you heard of any antioxidants that are used in chronic pancreatitis? Derivatives. So this is an interesting thing. Now, enzyme supplements, there's no evidence. There's good evidence that a cocktail of antioxidants, including methionine and things, can improve pain. Okay. partly due to this chronic inflammation and the oxidative stress theory in chronic pancreatitis. So some guidelines recommend for use of that particular cocktail of antioxidants. Again, I've given you the resources. You can read about what cocktails are useful. Then let's come to the interventions. Now, these are the two guidelines that we are going with mainly, right? They have long, complicated routes like this. But the most simple, elegant decision-making paradigm is this one. Does anyone know what this is from? This is from an old textbook of surgery called Farquharson's, right? And this pretty much summarizes the interventional workup that we have. There are things to add to this, but we can start here. Because, like Dr. Malik mentioned, pain comes due to one of three reasons. Either ductal hypertension or ongoing inflammation, or without both of those, neurogenic. So your initial imaging, your CT or your MRI can guide you in those directions. If you find an inflammatory mass somewhere, then it's probably due to the ongoing inflammation. Get rid of that mass. If you find that there's a dilated duct, it's probably due to ductal hypertension. Okay? So some people, they have, if you go through this, we'll go with this one first. They have a dilated duct, but there is no involvement of the head of the pancreas, no inflammatory mass or whatever. In those people, you just need to decompress the duct. Now, this mentions the lateral pancreatic vaginostomy. What do we do these days? If the duct is dilated. Next one, Mike. If you have a dilated duct and no inflammation of the head or whatever,
Stent placements.
yeah, we can do an ERCP and place a stent, right? That has various advantages. One thing is, just because the duct is dilated, we don't know whether the pain is due to ductal hypertension or not. Yes, it might be neurogenic pain. Okay, and if we do a huge procedure and this and the pain is still there, waste, no? So stenting is a very elegant, very simple, minimally invasive way of us not only settling the pain, but also diagnosing accurately that the pain is due to ductal hypertension. Okay. So let's say that someone has no dilated duct and no inflammatory masses anywhere else. Then what is the most likely cause?
Neurogenic cause.
Neurogenic. And that's where we go with our neurolysis. It can be a splanchnicectomy in the thorax, right? Or it can be, what else can we do? Celiac plexus ablation or celiac plexus block. Okay. So what's the difference between a splanchnicectomy and a celiac plexus block? Next one. What do you do in one or the other?
Usually in the celiac plexus ablation, we are giving the ethanol to ablate.
How is it done?
Endoscopically or percutaneously we can do.
Yeah. Endoscopic ultrasound or radiological guidance. Yeah. Even surgical celiac plexus blocks can be done. We can open and break it out. What's the difference between that and a splanchnicectomy? Next one. Okay.
No ideas.
Right. So, so you can't say don't know and send the mic across. Okay. You have to keep the mic with you then because you'll have to answer the next one. Right. So the difference is the celiac plexus contains both parasympathetic and sympathetic inputs in it. It gets its parasympathetic inflow from the vagus and it gets its sympathetic inflow from the splanchnics. and both of them mix together and create the celiac plexus. Most of the pain is carried by the sympathetics, which is why the splanchnicectomy is somewhat like a sympathectomy. You are cutting off the sympathetic in outflow from the viscera to the central nervous system. And that reduces most of the pain. But if you want to target the final common pathway which it's all coming up from, you have to block the celiac plexus. It's like giving an H2 blocker versus a proton pump inhibitor to reduce gastric acid. You can block the final pathway, you can block the most common culprit. So obviously a celiac plexus block is more effective than a splanchnicectomy. Right. So that is two of them covered. Sometimes there is no dilated duct, but there is a lot of inflammation in the head. There, you have to get rid of the head. So you have two options. Either you can do a classic Whipple operation, or because you don't have anything against the duodenum and the bile duct in this patient, right? They have not done anything to trouble you. You can leave those two behind and just go out the head of the pancreas, unlike in malignancy. So that is called a Buger's operation, right? And lastly, we come to this top corner. In some patients, you have a combination of this, where there is a dilated duct and an inflamed mass in the head. So you have to combine a lateral pancreatitis with a Buger operation. You combine those two together, that's called a flow operation. Okay. So this is kind of the description of what's done, right? If you have an inflammatory mass in the tail, you don't need to do anything else. You can just do a distal pancreatectomy. Spleen sparing or spleen with distal pancreatectomy and splenectomy. What do you think?
Both together, distal pancreatectomy and splenectomy.
Why?
Because there can be, it can further attack can cause splenic artery aneurysm and splenic vein thrombosis. In that case, also we have to.
But once you take the tail out, that area is clear. Your answer is right. The answer is, unlike in malignancies, it's really difficult sometimes to preserve the spleen here. Malignancies, you have nice tissue planes, right? If it's a non-adenocarcinoma tumor like a cystic neoplasm or something in the tail or a neuroendocrine tumor, you can do a spleen preserving distal pancreatectomy. Here, if you can do that, it's ideal. But sometimes it's difficult because there's so much inflammation. You're doing it because there's an inflammatory mass. Sometimes it's difficult to preserve the spleen. But if you can preserve the spleen. Okay, so you can do that. Yeah, here it's a Whipple operation, right? This is a frame where you have coiled out the head as well as opened up the tail. Here it's just a side to side pancreaticojejunostomy epiustos operation, right? And here it's a bigger procedure where you have coiled out the head but left the duodenum behind, right? So all these options are available, right? The classic operation we do now for the dilated duct is not a Cousteau. It's a Partington-Rochelle procedure, the side-to-side anastomosis that you see there. Cousteau described the procedure earlier. He was just after Whipple. During those times, people didn't even have proper sutures to suture the pancreas. They were suturing the pancreas with catgut after doing Whipple operations, and everything was leaking because they didn't know that pancreatic enzymes were digesting the sutures, the collagen in the sutures. So, because they were so afraid, what they did was they would do a splenectomy, mobilize the entire tail of the pancreas, cut the duct wide open, and then push the whole thing like a banana into a bowel loop and stitch at the neck and leave it inside like that. That was the Pusto operation. Okay. Only after they worked out pancreatic enzymes and good suture materials, and we had good non-absorbable or long absorbable sutures like polydioxanone and polypropylene, did Partington and Rochelle come up with the side-to-side anastomosis. So that's what we usually do now. It's a variation of the Pusto. Okay. So basically, what's better? Endoscopic decompression or doing a surgical decompression? That's the next question.
I would prefer an endoscopic decompression here, sir.
Why?
Because a surgical decompression is always an invasive procedure. So less invasive means less complication of the patient. And
yeah, okay. So it's a less invasive procedure. That advantage is there. Also, like we mentioned earlier, you're not sure sometimes whether it's ductal hypertension or not. So surgical decompression first is better. Sorry, endoscopic decompression is better. What else? Any other opinions?
So if the patient responds to endoscopic decompression, then as a permanent procedure, then we can go for.
Why? Why can't you stent again? How long does a plastic stent last for?
1 year, you have to replace stent.
Plastic stent lasts a little less longer. How long would you usually change at 6 months? Is it Malit or?
Keep for 1 year because of lack of stents.
Stents, yeah. Okay, so that's a. Yeah.
The longer, the better.
Sure. So yeah, but you have to change it at some point. So, what do you think? Any other opinions? What's the evidence? So that's where the escape trial we talked about earlier comes in. Our traditional practice is also to stent these patients and leave them. But there is an increasing body of evidence now that surgical decompression is better than endoscopic decompression. We don't know whether that will change in the future because endoscopic decompression is also getting more and more specialized. People are going into branched ducts now. They are using spyglass scopes to take the stones out of the small ducts. That evidence hasn't come yet.
If the intraductal hypertension is due to stricture, you don't have to stent forever. You can put stents multiple times, and when the stricture gets dilated,
yeah.
Of course, you can do a trial without stent. And this is not an algorithm, PRCP, ESWL, surgery. You have to select what is best for that particular patient. If you have a patient with multiple stones around the entire duct, I don't think ERCP is beneficial. If you have a single duct or single stricture causing duct dilatation, then ERCP is good. That if there's a stone which we can't negotiate this guide by our stent, then if the stone density is less than 1,000, you can try ESW. So likewise, there is no right or wrong answer to this. It depends on the patient, stone density, stone burden, and the duct dilatation, everything. So surgery is not selected as a fail, when all the other treatment options are failed. If surgery is indicated, that should be done at the outset. Then the outcomes are better. Because if the duct is dilated for a long time, there is a parenchymal pressure. I don't know what the evidence says, but now this treatment does not reduce the progression of the disease. But if you drain the system at an early stage, it reduces the parenchymal atrophy, which in turn reduces delay the progression into endocrine, but does not completely cure the disease.
Yeah, exactly. So this is kind of an illustration of the case that Malik was talking about. So this patient has some peripheral calcifications, but it was a single stricture at the neck of the pancreas that was causing that huge dilated duct. Okay, so we get a stent across that, and I don't have the subsequent images, but about 6 months later, And during the second contrast study, contrast was freely flowing out again and the stricture has settled. In those cases, this is far better than going for a invasive procedure, right? For a surgical procedure. But if you discuss evidence, you'll have to be updated on that because there are some centers overseas that advocate surgical decompression over repeated endoscopic decompression because apparently long-term pain management is better. Now, does this help with exocrine improvement, the stenting? Will they have better absorption? Yes or no? Once you do this, will you be able to reduce the enzyme supplements? Yes? No. Will it improve the diabetes? So remember this also. Duct decompression or all these surgeries, they are solely for pain management. Right? Yes, if they are done early, sometimes they might reduce the progression, but they don't improve anything. So sometimes you might get that patient with a hugely dilated duct, right? Or a big mass somewhere, but they are quite fine and with some paracetamol they can manage. You don't do any interventions in those patients. You don't treat the imaging, you treat the patient. Okay, so that's a bit about that. Lastly, about nutrition. So again, I just stop here because we are running out of time by just mentioning that we talked about the anthropometric assessment and the biochemical things that you need to do. Nutritional assessment in chronic pancreatitis is very neglected. It doesn't stop just at doing a full blood count, a serum albumin level, and starting them on nutritional interventions, right? So this is the set guideline from the ESPEN. These people need the DXA scanning to check for bone density, not just the X-rays that you were talking about, right? We need to check iron studies, fat soluble vitamin assessment, everything. Especially vitamin E is supposed to be a predictor of whether the other vitamins are deficient, right? You have to do skin folds on them, you have to do grip strengths, right? So we'll talk later about how we do all this, and it's very difficult for you as a surgeon to do all this. So it's good if all your chronic pancreatitis patients are, like you mentioned earlier, also followed up by your nutritionist. Right? It's not something that you can manage alone. The endocrinologist and the nutritionist have to work together while you are managing the pain along with the pain team.
Under-recognized.
Yeah.
Because we think we have a lot of sunlight, we have a lot of vitamin D. It's very common, especially among these patients, vitamin D deficiency. If you don't correct that, they will have all sorts of pains and aches and pains. Have to diagnose that and start treatment.
Right. So overall, this is from the British guideline. This is what you need to do in the clinic. There are things that you have to do at diagnosis and things that you have to do at follow-up. Again, you don't need to take photos of this, go through the guidelines. I've given you the resource, right? And lastly, you might be asked a few words about these new things that are coming about. Have you heard of EPIAT? If you can't sort out the pain with anything, what do you do for these patients? So, EPIAT is total pancreatectomy and autologous islet cell transplantation. You do the pancreatectomy, you harvest the islet cells through chromatography, you separate them out, and you auto-transplant the islet cells to maintain their endocrine function whenever possible. That's also another option for pain.
consensus says there is no guarantee that the pain is cured even after total pancreatitis.
Yeah.
The retroperitoneum is fibrous and the nerves are infiltrated. Even total pancreatitis is not going to cure the disease. Total pancreatitis, I would not consider that as a treatment. We are making another patient with permanent endocrine and exocrine failure. In this country, it is like a dead leg.
Yeah, because we don't have the islet transplantation, and even islet transplantation doesn't work all the time. So you are going to have the brittle diabetes that you talked about. Have you heard of chemical pancreatectomies? That's another thing that is coming up. It's done with ERCP. You do an ERCP, you cannulate the pancreatic duct and you inject acetic acid and destroy the pancreas chemically. That is also something that is coming up. You need to read about that a bit. Then there are some calcium channel blockers which have been suggested will reduce inflammation. These are also used in acute pancreatitis, as well as chronic pancreatitis. So you might have to read about them in the future. These might be some areas that we talk about. One thing I forgot before going on to that was, where's the mic now? Enzyme supplementation. Who should get enzyme supplementation? Next one, enzymes.
Those with exocrine failure.
Yeah, so we assessed exocrine failure with anthropometry as well as with things like stool elastase and fat. If any of those are deficient, you need to get enzyme supplements. What do you give? Next one. What do you give for enzyme supplements?
Creon.
Creon is a brand name. So we give them pancreatic enzyme, right? How do we generate it? Is it from animal origin? Is it synthetic? How are they supposed to take it? How do you calculate the dose? Next one. How much should they get?
I can't remember the weight-based dose. So roughly around 50,000 units TDS. With generally taken with the first bite of the meal.
Yeah.
You don't bite it, you just swallow it. And it's taken with every meals and also supplemented snacks you get.
Yeah.
So 6 doses, but until Sri Lanka.
Yeah. Is it available in the government sector?
It used to be available, I'm not sure if it's available right now.
Yeah. So it's one of the few things that are actually produced in Sri Lanka these days also, right? So it's made in Sri Lanka, but sometimes it becomes unavailable. That's the biggest problem. Yeah.
Now there are several brands beyond your side pancreatic. Because it has third and expand regulation.
Yeah.
Good old days, 2 years back, 3 years ago, no other choice. Programs.
Okay. Yeah. So one more thing. What do you know about? You talked about autoimmune pancreatitis a little bit, I think. What do you know about hereditary pancreatitis? It's a common it's not a common cause, but it's an important cause of chronic pancreatitis. Next one. What do you know about hereditary pancreatitis?
No, sir, no idea.
What's the difference between familial pancreatitis and hereditary pancreatitis? Anyone? So this hereditary pancreatitis is a dangerous condition because it is considered pre-malignant, isn't it? No.
Cancer. It's a risk of pancreatic cancer, but hereditary pancreatitis has a higher risk of pancreatic cancer than alcoholic chronic pancreatitis.
Yeah.
But if hereditary pancreatitis patients start drinking, I don't know what.
Yeah. So hereditary pancreatitis, we don't pick up these things because we don't check the genes, right? Now, there are other causes of familial pancreatitis, cystic fibrosis, alpha-1 antitrypsin deficiency. Those causes are also familial. But hereditary is an autosomal dominant one, unlike the others. And so they have a 100% chance of going into the next generation. And you'll probably need to know a little bit, at least for MCQs, about how it's transmitted and the risk of malignancy. In these people, sometimes, even if the pain is not controlled overseas, they do total pancreatectomies because if there is exocrine failure and endocrine failure in these patients, the surgeons sometimes decide they anyway have the exocrine and endocrine failure. All that is happening if you leave the pancreas behind is increasing the risk of malignancy. So they might even do a total pancreatectomy, right? So, yeah, that's a exception, but you'll need to know a little bit. Right? Any questions? We'll go around and answer
I'll
any.
ask a question. If the patient has a pancreatic head mass, known patient with chronic pancreatitis, abdominal pain, acute attack, and during evaluation, you found that patient has a pancreatic head mass. Right. What are your thoughts? How would you proceed? Quickly, we have only 15 minutes. How would you evaluate this patient? Diagnose patient with chronic pancreatitis. If you want, you can say extra and endocrine failure also. How would you evaluate? What are your worries? What are the DDs? Inflammatory mass versus malignancy. Right. So what do you want to do now? How do you differentiate between the two? So imaging is anything to say that this could be malignant?
Maybe if there's a mass without duct involvement, maybe. Or else the metastatic features could be there.
There are
in the
metastatic features, either regional or non-regional low metastatic features. Okay.
And also calcifications may also more in favor, but still we cannot 100% exclude.
The diagnosed patient chronic pancreatitis.
In that case, a main worry is whether it's an inflammatory mass or a malignant mass. Given the fact that patient having a malignancy, patients, the chances of dying is more if we don't give some intervention for that. So, and also we can't.
You said you wanted histology. What would you do?
Then again, sir, we can't exclude malignancy with one corneal biopsy. If
So you can take several courses.
But I think given the benefit of the patient, going for a Whipple's may be more beneficial to differentiate the two because there is acceptable population of patient where the specimen comes as chronic non-malignant lesion.
I would say you can do a US and FNA. If it comes as positive, you know it's a malignancy stage and then do it with or without pneumonia. But if it does not come as malignant, because it's very difficult for the pathologist to report, even with the background of fibrosis, and to detect cancers is very, very difficult. And also you might not get the code from the correct site of cancer. So negative biopsy does not exclude. In that case, you can actually discuss with the patient and go ahead with because it's a huge undertaking. So then you can discuss and say there's a possibility of negative histology at the end, but this is what we can do. That's one. You have any different opinion on that?
Yeah. One thing might be the history. Before you just say it's malignancy or not malignancy, talk about the timeline that we talked about earlier. If this is someone who has had no symptoms at all, but recently they have marked loss of appetite, loss of weight, and things like that, then your threshold for assuming it's a malignancy might be more. While if it's someone who has had the same features earlier also, So there your approach might be you need to probably re-examine previous images, right? See whether this mass has been static over the past CTs as well. If that's the case, you're probably heading more towards an inflammatory mass, maybe. So you have to put all those things together. And are there any markers we can use?
See.
Yeah.
Markers for pancreatitis.
Huh? At least you have no, as undergraduates also, you know.
CA9. The two marks. CA19. Right. So if you don't, that also can be some idea. Doesn't confirm. But if the patient having inflammatory head mass and jaundice, CA99 is anyway high. You should never do CA99 when the patient is jaundice. Relieve it, keep it, leave it for at least 2 weeks and then do.
Any other questions? Yeah.
So in case of a chronic pancreatitis patient, in case we are going for surgical options, sir, and say, for example, it's in the setting of an obstructive jaundice as well. What about stent placement, sir? And like for how long do we need to keep the stent in place? In which indications would we go for a stent before going for the surgery?
Preoperative biliary drainage in the background of head mass, inflammatory in neoplastic, is indicated in several situations. That is, if the optimization or the time taken for surgery from the diagnosis is more than 2 weeks. 2 weeks is the arbitrary cutoff. If you can operate on the 15th day, you can just do it, right? So if the time taken from the diagnosis to the optimization or surgicalist availability is more than 2 weeks, you better drain it. And then the other one is infections. If the patient's cholangitis, you can't do a major surgery. If the require a neoadjuvant, again, you have to drain it and send the patient, because without draining, you can't give chemo. So those are the indications. The other one is intense pruritus. But again, if you can operate within week, just ask the patient to scratch for another 5 days. I mean, that is also not a absolute indication. But if you can ask the patient to scratch overnight for 2 weeks. So those are the indication to drain the system. If you drain it, you might as well take the advantage of the drainage. And patient appetite improves, hydration improves, and then if there is a coagulability, that also can be improved. So then get the advantage, wait for about at least 3 weeks, and then do it. Otherwise, you're not getting the advantage of draining the system.
So the question back to you is, what is the disadvantage of draining?
Delaying is not a major problem because pancreatic cancer does not grow overnight.
Stent migration.
Stent migration.
Fibros.
Anything else?
How it complicate as How? So that's the question, Avi. Why do we, in benign or malignant disease, why do we decide to operate without stenting, without decompressing? We have that option. But pardon?
Rate of surgical site infections are high with the stenting.
Yeah. So that's that's the answer. Sorry, it's the answer because the biliary system is usually sterile, and the moment you decompress it either externally or internally, it colonizes. So whatever surgery you do, it might be a pancreatic decompression for chronic pancreatitis or malignancy, you are now operating on a contaminated system instead of a clean system. So you are changing your clean surgery into a contaminated surgery. It's not clean contaminated anymore. It's contaminated.
Yeah,
and
the thing is, if the patient develop ERCP complication,
Yeah.
you are going to unnecessarily delay the not more than 2 weeks, maybe more. If the patient has bled and maybe duodenal perforation, maybe pancreatitis. If the patient develops post-CRC pancreatitis, surgery is going to be very, very difficult. There will be a lot of adhesions around the vessels. So if you can do the surgery, if the patient is fit, better to do it undecompressed.
So if the patient has an inflammatory mass at the head and the only problem is obstructive jaundice, what will you do? There's a large calculus or a mass in the head and the patient has jaundice. Doesn't have much pain, right? What are you going to do? Yeah, in those cases, I think without resecting the inflammatory mass, just ERCP and stenting and
You can even put a metal stent and keep it for some time.
covered metal stents are probably the best option there. Right? Any other questions? All right. Then I think we'll wrap up now. Is there anything else from Malit or Suchinta?
We hope you all gain something.
Okay then. Thank you everyone. We'll stop the discussion now.
Audio to formal lecture is better or the discussion is better?